safer community for all of us.
Won't you come
There
on
was
over?
so many choices when it came to
Stop
picking my health
making
in
a
Louisiana.
fool out of me.
I didn't understand all the options. I just wanted to know what was best for me.
We know the last thing you need to worry about right now is insurance. That's why AmeriHealth Caritas Louisiana is dedicated to making your health care as easy as possible so you can focus on what matters most. AmeriHealth Caritas Louisiana helps people in difficult situations. We make sure you have access to everything you need, from dental and doctor visits to medicine for chronic conditions like diabetes and hepatitis. We also give you 24/7 access to member services and nurses who can help you to understand your options, make appointments, and even get rides to the doctor. But we know that making sure you're well means more than just going to the doctor. That's why we offer services that can get you back to your life. Our care managers work with members to help with things like finding housing, getting your GED, and can even provide cell phones at no cost so you can call or text us for help. We also offer help with mental health and substance use treatment services.
I didn't understand my treatment or know how I was going to get my medication. AmeriHealth Caritas Louisiana made it easy. My case manager showed me how to take my medicine and made sure I can get it when I needed it. She really cared about making sure I was okay. She told me that care is the heart of their work. I believe that.
Your health is important to you. It's important to us too. Let AmeriHealth Caritas Louisiana take care of your health needs so you can take care of your life.
With the Health Anywhere app, urgent care is in the palm of your hand. Accessible from your smartphone or tablet, the app lets you see a healthcare provider and get prescriptions anytime and anywhere in Louisiana. Whether you're a busy parent juggling schedules or just someone dealing with a late-night sickness, Health Anywhere is changing what it means to see the doctor. It's the waiting room redefined. Health Anywhere. Download the app today.
Health insurance has never been more important. A no-cost health plan that's #1 in member choice, Louisiana Healthcare Connections is a family of nurses and providers who care about you and your health. Visit ChooseLouisianaHealth.com. Your health, our purpose.
Good morning. So welcome to the third annual South Louisiana Community Health Summit. And I want to thank all of you for attending, those people that are here live and all those that are joining us virtually. We're so happy to have you here this morning. And we're just ready to get started. So we're just gonna jump right in. Our theme this year is borrowed from a Beacon Community Connection core value, Better Together. And I just wanted to talk a little bit about what that means to me. So with the help of friends, colleagues, and other passionate people passionate about improving our community, I started Beacon a little over 2 years ago, and I could not have done it alone. And we've continued that idea of Better Together. Our main focus is on non-clinical case management. We help people in challenging situations like chronic medical conditions by connecting them with resources that allow them to heal and thrive in our community. And I'm only going to bore you with a couple of statistics. So patients under our care are 70% less likely to return to the hospital within 30 days. And they're more likely to avoid unnecessary medical costs. And it's estimated that we saved one healthcare organization over $11 million through cost avoidance. Beacon is powerful because we know we are better together. So we work hard to collaborate with hospitals, jails, social service organizations, and government agencies. And if we're not working with you, we would love to. When I started Beacon as a nonprofit, I knew we'd have to fundraise to offset costs, and it's not something I was very excited about. I didn't want to do a fun run or have a fancy gala. I wanted to have events that improved our community, and as a lifelong learner, community education was just a natural fit. So our Community Health Summit is our premier annual education event. And this year has been tough for everyone, especially our faithful sponsors. So I would like to thank our gold sponsors, Hospice of Acadiana, Lafayette General Health, Louisiana Healthcare Connections, and VieMed, as well as our silver sponsors, Acadian Companies, Candesto, Compass Healthcare, the Haney Family Foundation, Oceans Healthcare, and AmeriHealth Caritas. This summit would not be possible without their generous support. So thank you to all our sponsors for believing that we are better together. As y'all know, the Cajun and Creole cultures are built around conversation. Y'all love to pass a good time by making jokes and telling stories. And we're gonna do that today, together. The summit planning team has curated 4 community conversations about COVID-19 and how it has impacted our community. Our first conversation has healthcare leaders talking about their journeys over the past few months. Then we're gonna focus on how outside COVID policies get implemented right here in South Louisiana. Our third session takes a hard look at health inequities and what we can do for our most vulnerable neighbors. And finally, we will look towards the future and talk about how our community will move forward together towards health and wellness. When we had to pivot to a virtual venue, we wanted it to be different, not just a Zoom call with 150 people. So we settled on the idea of a daytime talk show format. Think Ellen, not Jerry Springer. However, we needed just the right host, someone connected, someone personable, someone who was a good listener. And our planning team knew instantly who we wanted, Jan Swift. You may know her as the host of the Discover Lafayette podcasts, but I know her as a friend. So please join me in welcoming to our summit our host, Jan Swift.
Thank you,
Thanks, Jan.
Holly. Thank you so much for joining us today. I have to share with you, Holly Howitt is one of the most organized people I've ever met, and she actually started planning this summit the day after the 2019 summit ended. And she knew that she wanted to share with the community and the larger state and region about the importance of knowing the social determinants of health. But as the COVID pandemic unfolded, of course, she had to pivot, as you all have in your industry. And so I think the timing of this South Louisiana Health Summit couldn't be better. Beacon Community Connections has gathered the top healthcare leaders, and they're going to share their collective wisdom and experiences in how they're dealing with COVID, what's happening on the front lines, and also how are they treating and addressing their patients for an illness that none of the textbooks prepared them for. I believe that the synergy of their voices is going to make for compelling discussion and also dispel some misinformation that may be out in the community. I'm honored to be a part of the summit, and I feel great to be at the table with some of the best of our best. So we're going to start with session 1, which is Systems Challenges as Opportunities for Advancement. And our first guest is Dr. Amanda Logue, a graduate of LSU Medical School, and she's Chief Medical Officer for Lafayette General Health. Dr. Logue has led physicians in transitioning to a fully electronic medical system, record system, and developed an informatics team focused on improvement through the use of technology. Board certified in internal medicine and clinical informatics, Dr. Logue believes in the power of scientific research and its efficacy in providing the best treatment options for patients. Dr. Logue, will you please join me and have a seat up here? Please welcome her. And I think you can begin your 10-minute talk.
All right, thank you for having me. This is quite the pleasure, and I've been working with Beacon for a couple years, so I'm very excited to be a part of this summit this time. I'd like to first start off by thanking all of the healthcare workers that we work with every single day. This has been a tremendously trying time. None of us were ever prepared for what we're dealing with, and every single person that I know that works in healthcare, frontline workers included, have just stepped up to the plate and continue to do so every day, and we would not be here without them. I just wanted to talk a little bit about how we've had to adapt to sharing information in this time period because it's really been unlike anything that we've had to go through before. We're very used to working off of things like protocols and evidence-based medicine and standardized treatments, things that we've relied upon for years to make good decisions and to understand what our outcomes are going to look like for our patients. That certainly doesn't mean we don't have surprises. I think any person who takes care of people will certainly let you know that they are surprised sometimes, and things are unplanned. However, we still have ways to go about getting information, doing literature research, using our colleagues and our networking to try to figure out how best to treat somebody who is not responding the way that you would have anticipated. And certainly we're all trained in things like emergency preparedness. So we're ready for things like mass casualty, mass trauma, hurricanes, environmental disasters, chemical exposures. Those things come on abruptly, but you work on triaging, you treat, then you work on recovery, and you usually have an end in sight, something that is, when that disaster has passed, you will kind of get back to normal business. The difference this time, of course, is that we're dealing with an incident command situation, a disaster that has happened with all of us learning how to treat it at the exact same time, and no end in sight in this. So that has been very challenging to go through that scenario without having a lot of experience at all. We didn't have any kind of research. We didn't have any kind of trials. We've seen respiratory illnesses before, but never in this level, and this was certainly something that was very unknown throughout the world. And we could see the pattern of treatments happening different places around the world at different times, and we were attempting to adapt to it as fast as we could whenever people were ending up in our area sick with the same disease. We were using a lot of word of mouth, which is very unusual for healthcare. We usually have a lot more things to back ourselves up on and to use for information. This was very unusual for us to have to rely on communication at the time frame that you needed it to try to take care of people for a disease that you had never seen before. And so we had to create our own in a lot of scenarios. We didn't have something that facilitated that for us. So all around the world and the country, people were spinning up their own versions of how do we share information quickly, because we needed to. The problem, one of the worst problems about this was the people that had the most information, all of it anecdotal from limited experience, but they had the best information to give us, were also the people that were still dealing with a full-on pandemic in their health systems. They were exhausted. They were still very much needed at their locations, and many of them were sick themselves. So that was a challenge in and of itself, to ask for more time to help your colleagues and help others to be able to plan for what was coming their way. It was even more challenging for them. So we had to develop some channels, and we did so locally with my other colleagues that are going to be on stage. The three of us were involved in some local organizations that we got together rather quickly, where we could get our leaders, our healthcare leaders, together on one phone call as often as we needed to, and we could take that information and then disseminate it in our facilities or our employees or wherever we needed to. We would certainly talk about things like treatment protocols and experiences, how you saw people coming to your facility. What did they look like? What kind of symptoms did they have? We certainly wanted to know about testing. When do you test? How do you test? What does it look like? How fast is the turnaround? And what kind of outcomes were you seeing? Is this something we should try, or don't even bother because it's not working? One of the interesting things we had to talk about, which we don't usually have to, is personal protective equipment. That's usually a supply thing that's generally fine in a situation. But in this particular situation, as you know, we were desperate, and there was a lot of concern about having the supply when we were going to need it at the worst time. I remember one phone call that we had, one of these physician local leader phone calls with Dr. Burnell was telling us about pathways that he was able to find extra PPE through Amazon if we were to go on and notify Amazon that we were a healthcare facility in need. We could get additional supplies. And that's the kind of stuff that we ended up having to talk about on these. And we would walk away from those phone calls. We would then go to our own local networks, share that information, and then do it all over again as often as we needed to in order to try to get the right information out. Also, we were trying to help guide the national and local leaders. They were looking to us for answers, and we didn't always have those things. And so that was very hard. At the same time, understanding that typically we can give really good information about what we're seeing, if there's a rise in something like cancer or hypertension. We have some data behind that. But in this scenario, we really didn't have a lot of answers, although we tried to give the best information we could. We also spent, I can speak for the group of us that's up here, that we spent a lot of time handling misinformation and bad communication that was out there. We had to constantly be educating our friends and our family, sometimes the leaders, our patients, our colleagues, on what was the right information to go by and what wasn't. And personally, I can say I wasn't always sure that was the right information. I was going off of the very best information I had, but given that this was unfolding as we were going through it, it was very difficult to know for sure if this was going to be the right thing to say. So I think ultimately, I know that we were not the only group to do something like this. I know this was happening all around the world. And I know that because physicians that I work with were also using their channels at other communities that were feeling the same amount of COVID patients and dealing with that. But I do think that it really shined a light on the fact that we don't have great processes within healthcare to share information that rapidly. Eventually, a lot of national networks and global networks of physicians and nurses and all of the healthcare worker communities ended up kind of getting into place and getting their information out quickly. But it could have probably been done a little bit sooner. Very similar to a way a hospital will jump in with an incident command system when they have an emergency situation. You get all the people around the table, you share the same information, everybody hears the same thing, and you have the opportunity to ask questions and clarify. In addition to being agile and sharing information like that quickly, I also found I still find interesting the way in which research is being handled. So, typically the common public doesn't really is not truly aware about, more than 350,000 clinical trials are ongoing worldwide every single day. That's just something that has been happening over decades, and honing that process, and they're not truly aware of it. The majority are not, and that's fine. They're also not. The majority of the public is also not really clear about the stages of research, the phases that we have to go through, and the oversight and the safety and efficacy that's in place for us to develop a good protocol. What happens in a really well done study is that you end up with trusted data, you end up with peer-reviewed data, and you end up with information that you can take back and use for decision making on your patients. In this particular scenario with COVID, we've had to go through the scrutiny of how research is conducted at the same time that we need the research to be conducted. And I'm not saying there's not opportunities for improvement in clinical trials, but there also is a lot of misunderstanding out there. And so what I'm worried about is that with that misunderstanding, there has been some mistrust in the processes, which ultimately may lead us to not being able to use that data on patients as well as we would like.
Dr. Logue, thank you so much. I've got so many questions I'm already thinking of. We're going to have all of our speakers give their presentations before we start more discussion. Our next guest is Dr. Charles Burnell. He's Chief Medical Officer of Acadian Ambulance. Dr. Burnell is a graduate of LSU School of Medicine and is board certified by the American Board of Emergency Medicine. He serves as lead over other associate medical directors across Acadian's service areas. And I know from experience that Dr. Burnell's heart leads him to protect his employees as they suit up every day to provide emergency services. And you can't think of anybody that's more on the front lines than Dr. Burnell in Acadian Ambulance. Thank you so much for joining us.
Thank you for that warm welcome. I've got a little presentation here that I'm going to just give a few slides. And one of the, Dr. Logue did a wonderful job of outlaying a lot of the challenges that we're dealing with from a medical standpoint. And let me see here. Let me just get this first slide up. There we go. Okay. One of the things that was interesting and still continues to be about this event is how to get accurate information out to a remote workforce or even the community as quickly as possible. As we watch this disease process progress from overseas, and Dr. Logue and I were talking about this earlier, it was kind of like we were a little bit insulated from what really was happening just because of the Atlantic Ocean between us. But as this thing progressed into here, it became real very, very quickly. And hitting the road, running, and trying to figure this thing out with very limited information, and also a lot of misinformation out there was a big challenge. And one of the things as a healthcare provider in a company that has the responsibility of caring for communities, getting good, accurate information to take care of those that we serve, those patients that we take care of, and also to protect our workforce were two of the very big focuses early on in this and continue to be two of the large focuses that we had to really prioritize. One of the things that I did, and it became apparent very, very quickly because of the media and a lot of things that were going on, that we really had a need to get accurate information, to get that information out quickly. And if we didn't, then people would fill those, what I call information vacuums or gaps, with whatever they could find on the news media, on social media, or anywhere like that. And there was a lot of rumor, and there was a lot of fear, and there was just a lot of disruptive information out there that prevented us from doing our job. And Dr. Logue had mentioned the PPE, personal protective equipment. You know, what is the right equipment to use? Who do we need to use it on? How do we need to test? We knew that we were going with our first responders and paramedics and whatnot going into areas where these are known COVID patients. There was no way to avoid that. Like Dr. Logue's team and Dr. Kaufman's team, that's our job, that's what we do. But how do we do that safely? Because we knew that decimating our workforce and having the inability to care for those communities was not an option. So some of the big things that we did, we started trying to do the memo thing like we're traditionally doing, and that just did not work well. People were coming to me and the other leaders in the organization. You think this is true? Do you think that is true? I mean, what do you think about what I saw on CNN last night? What do you think about, you know, my brother-in-law sent this to me on social media, and we just got inundated with questions. And it's hard enough to go through and try to figure out the medical research data and all the social media data and all the news data, and especially when you have a lot of that conflicted, and you never know where that's coming from. So one of the things that I did, and I'll talk a little bit about opportunities, this communication channels, I had opted to go ahead and just, you know, I started off trying to do some videos, and I did for probably the first almost 2 months, I did daily videos, 7 days a week, with our employees. And of course, you spend a lot of time going through the data because you want to make sure that what you're presenting is accurate. So spend a lot of time just researching and going through things to make sure that those employees that we need to empower with information have the right information. And I started off with a fancy video camera, and that was just you know, these things a lot of times are spontaneous. As you know, this pandemic has been spontaneous, and when we go through information on a very rapid, you know, changing basis, you have to be able to adapt to that very quickly. Doing little videos and whatnot with this was really a godsend to me, to be able to be that source of information, to be that accurate source of information, and to disseminate that quickly. Video technology, you know, like I said, we started out with fancy stuff. Eventually, it was an iPhone that I had come to, and I even got a lot of feedback say, you know, it seems more genuine, it's not as polished, it's more real, I guess you would say, kind of Jay Cantori-ish out there in the storm, you know, and they could see me, they could, you know, visualize me. But that video technology, very quick, very easy to disseminate. Trying to keep the cost down on this, trying to keep the information accurate, and, you know, the written word, people don't check emails like they should. We have an internal intranet. People have, you know, the regular internet. They have social media, and try to consolidate that into one thing. I could do it very, very quickly by video, and I could snap a message out very quickly. It was not as polished. The lighting might not have been as great as we have in here. But that was, and the other thing with our workforce, we have workers that actually in almost 30 states. We principally are in 4 states, but trying to, you know, in 5,000 employees, trying to get those employees looking at one source and getting the right message every time is a challenge. But the other thing is when you're looking at distribution of these materials, I mean, it has to be very accessible, and this is what people communicate with nowadays. This is the message that they get. But what I've done is, to wrap up, is I've been able to keep these employees engaged, become their single source of accurate information. You know, and I even hear a lot of them, and it's a compliment to me that they would say, well, I saw this and this and this, but Dr. Burnell said this. So then I became that credible, verifiable source of information, and that was the eventual goal, was to make sure these people were armed with the information, because as a healthcare provider, any of you that are in healthcare, I would not doubt that countless people come to you to ask advice, to ask opinion, to ask for help, and you become that resource. You know, everybody has a, quote, nurse or a paramedic or a doctor in their family that they lean on hard to get accurate information, and there's a responsibility that goes with that. None of us want to miscommunicate. So the ease of that transfer of information, the responsibility of getting it down, for me, the video was the way to do it for the remote workforce, for large numbers of people. And it really, those messages are easy to go back to and refer to, and I would keep those things very, very short. My attempt was 2 minutes, but those of you that know me, I'm actually pretty shy once you get to know me. But that was a joke. But sometimes I can be a little verbose. But 2 minutes to me was a challenge, but that is about the attention span of most people with a video. Some of my videos went a little bit longer if we had a lot of topics, but the intent was to make it quickly accessible, easily transferable, easy to repeat the view and go through, and really easy to disseminate. So the iPhone was my choice, and it was really nothing fancy, but it worked very well for us. So I'll entertain any questions. There's a lot more I could talk about, but I will keep on track here for the sake of time.
You know, Dr. Brunell, as a consumer of healthcare, I think most of us, we just want to get treated. We're not really thinking about the people treating us. You know, that you've got to stay healthy so that we can get healthy. And so I'm really enjoying the behind-the-scenes look at what everybody's been going through. And we're going to ask one of your colleagues to join us. Dr. Henry Kaufman IV is Chief Medical Officer of Our Lady of Lourdes. A native of Abbeville, Dr. Kaufman graduated from LSU School of Medicine. He specializes in surgical oncology and is board certified in general surgery. And as an aside, I know that you became known in the media along with Dr. Logue for your video and also a letter that was never intended to get out into the public, where he was imploring people to listen to the healthcare experts, wash our hands, wear our mask, and adhere to social distancing measures. So Dr. Kaufman, thank you for joining us this morning.
I think Amanda and Chuck did a great job of laying out exactly what we were going through at the time from the perspective of, you know, how do we pivot toward caring for an entirely new disease? How do we pivot an organization and fighting disinformation and getting information out? Perhaps the best information I can give you this morning is perspective on how this was affecting the hospitals internally and our decision-making process as all this was going through. So to kind of jump back on the timeline, the first case of COVID-19 illness was in December in China, and it was around the first of the year that World Health Organization started getting involved. And about halfway through the month of January that they actually declared a world health issue. We then start seeing cases in Italy. Italy's got a fairly similar population to the United States in regards to longevity, our healthcare systems, and we're seeing dramatic spikes in cases. They're experiencing death rate of 14 to 15%, and that put the entire world on notice. It was shortly after that that we had our first cases in the United States, and before too long, the first cases in Louisiana. And within really 9 or 10 days of the first case in Louisiana was when Governor John Bel Edwards declared an emergency, shut down schools, and within a week or a week and a half of that is when we shut down all elective surgeries. And that has had the most dramatic and profound effect on the hospital's day-to-day operations of anything. It was a reasonable and sound thing to do at the time. You know, we're seeing dramatic uptick in cases in New York and New Jersey. New York hospitals are getting overwhelmed. We're seeing a similar pattern that we saw in Italy. We're seeing a geometric increase in cases locally, and we're looking and hoping and waiting it's not going to hit that logarithmic curve that it did in some places in New York and certainly did in Italy. We're also looking at a potential death rate of 14 or 15%, which is just dramatic and profound. And even as bad as New York was, overall their mortality rate in the height of the pandemic may have reached 5%. So they were in a crisis, their hospitals were overwhelmed, and we've learned in retrospect that the mortality rate in Italy and the higher mortality rate that we experienced in New York was probably a consequence of the healthcare systems being overwhelmed. So as we're learning that, our first goal in the management of the disease is not to overwhelm the healthcare systems. And that's a point that I think we've done our best on a national level and a local level, healthcare experts, to drive home. The curious thing about when we shut down elective surgeries was how quiet the hospitals were. And even though a quarter of our hospital capacity locally, and maybe a little bit more across town at Lafayette General, was occupied by COVID patients, because we weren't doing elective surgeries, because of the fear in the community and the public of going to the hospital, the hospitals were relative, I don't want to say empty, but they were very quiet. The surgical floors were basically clear. The medicine floors, we were missing a third of our strokes. We were missing a third of our heart attacks. We were missing a third or more of our new cancer diagnoses. And we were seeing a mortality in the public from our public health officers go up maybe not related to COVID because people were scared of coming into the hospital. Now, if you're facing a mortality rate of 10 or 15% or maybe even 5%, that's a very reasonable thing to do because we're looking at the resources that we're going to need down the road to deal with a crisis. Fortunately, that first wave abated without that logarithmic growth phase that we were all worried about, and the hospitals by that point had stocked significant PPE. We had started developing better ways of disseminating information, better ways of taking care of the disease, and a higher level of comfort of dealing with the disease. And that was one of our biggest challenges in the midst of all this as a medical community in how to respond to it, because you want to have a rational response, but you also want to have a healthy fear of the disease. Part of our biggest challenge in addressing the disease and how we're going to care for not only our team members but also our healthcare providers was how to mitigate against that irrational fear. And one thing that became obvious was the further that one was directly removed from patient care, the more irrational the fear of dealing with the disease was. The people who were dealing with it from day one, our EMTs, our ER doctors, the internists, the nurses on the floor, the ICU, they very quickly became comfortable. Now, they maintained a healthy level of fear and were good about their PPE and they were protected. And what we began to learn is, after weeks and weeks and ultimately months of exposure to this disease on a daily basis, is if we were just smart about this thing, if we wore masks, if we washed our hands, if we were careful with how we donned and doffed our PPE, we didn't get sick. And the fear, the irrational fear abated, and then you have a little bit of trouble with perhaps loosening or getting lax. And there were a couple of cases, a few cases of individuals getting sick within the hospital. And when I say individuals, I mean team members. But we can almost always trace that to some known event or break in the PPE process. For example, someone has a respiratory crisis in the ER and an emergency room physician rushes in, is charting on his chart. He's taking his mask off to grab a sip of water. Patient codes. He rushes in, not thinking to put his mask on, intubates the patient. Patient comes back with COVID. ER doc ends up getting sick. And it just takes some time to have all those things ingrained in us. The further we've gone in this pandemic, the better our comfort level, the better we've been able to manage that rational approach to the disease. And that has certainly smoothed operations, and we maintain a healthy respect for the disease. But on the same hand, we've figured out how to work within it. So the first wave passes. We get better at dealing with the disease. I think we were all leery of this coming second wave that we were all fearing, but had an enhanced comfort level in how we were going to deal with it. Again, we don't know where the growth is going. Again, we start seeing geometric growth, and we very rapidly surpass that 25% capacity number that we experienced initially in the hospital, and then we get to a 50% capacity in the hospital, and then eclipse that 50% number. That, fortunately, that peak came right about the time as the governor put the statewide mask mandate in effect, and what we all saw was an immediate decrease in the number of cases and the local transmission of the disease. And we've got naysayers, even the medical community, in regards to masking, and it's become a very hot topic. The clear evidence amongst multiple communities that have put masking effects in is that as soon as the masking goes into place and social distancing, that you do see a decrease in the number of cases. So at that time, even though we were dealing with over threefold the number of cases that we had during the initial pandemic, our comfort level and our plans that we all had in place mitigated against negative effects and enhanced our ability to take care of those patients. By that time, the restrictions on elective surgeries were not put in place, and in fact, the Louisiana Department of Hospitals left it up to the local facilities to manage their operations. And what that allowed us to do was to continue to take care of elective or urgent cases, while not putting off and not getting into as profound of an ethical dilemma of just shutting down surgery completely. Because when we say elective cases, we're not talking about plastic surgery or cosmetic surgery. We're talking about knee joints that affect people's mobility. If you can't walk, your health deteriorates. We're talking about people with spine injuries that may not have a neurological deficit, meaning they may not have muscle weakness, but they have severe pain. We're even talking about early stage breast cancer, early stage colon cancer, and other things. And that's a little bit shocking, but we've got really great data in the cancer community, for example, that an early stage breast cancer, as long as we initiate some form of treatment or therapy within 12 weeks, there's no change in their outcome. And we know that because people come into the ER all the time with heart attacks, strokes, et cetera, and we can't direct our attention to the breast cancer. That gets put aside, we recover the patient from their bigger health event, and then we address their breast cancer. And the reason that's the case is because likely in breast cancer that the treatments are so effective, it doesn't matter if we wait 3 months. And in fact, in a lot of circumstances, we can probably extend it beyond that. But imagine telling a breast cancer patient, I'm very sorry about your diagnosis. You appear to have a relatively early stage breast cancer, but we can't operate on you right now, and we're going to have to put your surgery off. And I don't know how long that's going to be. Let's get you in to see the medical oncologist and perhaps get you on a hormone blocking pill to slow the progression of the disease. But we're going to call you every week and let you know where we are and let you know where the plan is. So we had a lot of phone calls and working patients through it. When we hit the height of the pandemic in the hospitals, and that was over 50% capacity at Lourdes, we had to restrict surgeries to nobody was allowed to do inpatient surgery that required a bed. So any surgeries where the patient could come into the surgical platform, be operated on, and get home was allowed to proceed because we didn't have beds in the hospital. And not only were our beds full, but probably a bigger issue across the community was we were having team members get sick from community spread. And so we just didn't have the nurses and techs and staff that we needed to take care of these people. And so, barring an obvious emergency that would come in that needed surgical intervention, every case that proceeded on a daily basis was a conversation between several individuals in regards to the severity of the case, what our ability to take care of that patient in the hospital was, and what our bed availability was. And so my surgical, the surgeons as an independent physician, you are responsible for being an advocate for your patient. So my surgeons were having to advocate for their patients and coming to us and saying, we need to operate. And I had to advocate for the hospital and the community, and then we had to come to some negotiation. All those conversations were very cordial and remarkably understanding, and we were able to work through it. Fortunately, the numbers with the mask mandate came down, and we slowly opened up surgery to the point where now, for the last 4 or 5 weeks, we've had unrestricted access to the operating rooms, and we're able to maintain our bed availability. You can imagine there's a substantial backlog of cases, but again, our colleagues have been very reasonable in not overtaxing our already taxed operating room staff. So one of the biggest take-home points, at least from a healthcare system standpoint and trying to run multiple ORs and multiple platforms and preserve resources, is resources are best managed at the local level, and the state and their mandates gave us breathing room, but once we all realized where we were and what the resources would be, local control was the key to optimizing the amount of care that we could provide while still trying to get the community through the pandemic.
Dr. Kaufman, as you were speaking, thank you so much. You've each shared a different perspective on what's going on, and I don't know about our audience, but I envision us as soldiers, the individuals in the community. We have to suit up, and we have to arm ourselves, and the only thing we can do is listen to you guys. And it must be insulting to have people question medical wisdom and experience. You know, when you've either got people that are very skittish about going out in public and won't go out are people blatantly flaunting the requirements of wearing a mask that the governor, I think, has judiciously, called upon us to do. As you've each listened to each other, do you feel that you've gone from being possible competitors to true collaborators in moving forward? Is that what's happening with our healthcare? Not that you want to look at yourselves as competitors, but hospitals are profit-making arms of our community. But Dr. Logue, was there something that struck you as your two co-panelists were speaking about what you've learned in the last 6 months, where you are now as compared to March?
Yeah. Well, I mean, we went through this together, and the three of us plus everybody else that we collaborated with, educated. We grew up in this pandemic together. So, competitors are not in a market. That's going to exist no matter what. But when it comes down to what are we going to do to save our community, what can we do to educate people, there's competition is out the window. I mean, we have to be united in that, or one of us will fail, or all of us will fail, because if we're not sharing the same message to the best information that we have, we both are needed in this. We're all needed in this community to take care of the amount of patients that are here. So all of that goes away, and you just get down to business and share the best information you can. And we're all coming from the same background of medical training, and we work with all the same types of people, and we're all seeing the same thing. So I think we come at it from that perspective.
I'm curious, before I move to Dr. Brunel, do you have a stockpile of ventilators now? Like, did you buy up things at the beginning of the process and realize that wasn't the most effective as you gained experience?
As I spoke about, we did the best we can with the best information we had, and then we learned along the way. And we had a little dip there, as Dr. Kaufman was mentioning, where things eased up and we had some time to breathe and reflect and hone our processes, and continuing to learn from the rest of the world so that we could say, well, we've all realized that doesn't work as well, and maybe we don't need those anymore. So yeah, we have some extra stuff laying around that we don't need anymore, but as I said before, this is not over, and none of us are naive to think that we may not need it again. And so, we put that away, hold it for the next time something comes up, and it will be ready.
Yeah. Dr. Brunel, I know that numbers were down, as everybody was saying, people wanting to go to the hospital. Are things equalizing now? And maybe y'all can talk among yourselves, but I know for a while nobody felt it was safe to go to the hospital.
Yeah, so I think one of the gauges that we used when we worked together through this situation was, what do your volumes look like? That was a big question on a lot of the meetings that we had weekly. And yes, our volumes dropped substantially, which creates a whole nother staffing issue. You're overstaffed and you don't have the volumes to really support all those people out there on the street, but you also have a duty to be able to respond. So we probably had a 30 to 40% decrease, which lasted for a long time. That has since recovered somewhat with time. We're not back to where we were pre-COVID, but I'll say that we've adjusted our staffing models just like the hospitals have to do. It was an all-hands-on-deck affair for a good while there, and we've gotten to take a little bit of a breath. But you mentioned the competitive thing. I never sensed any competition. I think that adversity either drives people together or it drives them apart. And this community that we live in is a very cohesive medical community. And honestly, we would lend any information. There was no thought of competition. It was just try to care for the community as best we could. And if you can imagine people asking, what's it like trying to drive this information thing and make sure everybody's protected? Well, imagine yourself being a school bus driver with a load of kids behind you, and one of the kids gets very ill, and you're driving through thick fog in an area that's very unfamiliar to you, and you're trying to navigate this thing without harming everybody on the bus, but having another set of eyes to say, watch, there's a stop sign coming up, or there's fixing to be a turn in the road, or whatever, because that's really what you're doing. We're going into a fog here without really knowing all the answers and trying to navigate this bus down a pathway where everybody's safe in the end and we get our emergency taken care of, and that's kind of having these guys to shoulder a lot of the decision, a lot of the information. And look, we all review information on our own independently, and we all have access to different resources. I have an international resource that I met with weekly, a group of BMS physicians across the globe, that as this thing transpired from across the pond, from Far East to Europe and then to the US, we had real-time data from these guys overseas that we were, initially twice a week and down to once a week. We knew what to expect in advance, and that was easy to share within our community here. And it saved a lot of time sifting through all the stories on the media, and the unavailability of good research information, or even good anecdotal experience was one of the difficult things. But from a competitive standpoint, I really think the working together, the pandemic and the stress of all that adversity absolutely drove the healthcare providers in this community 100% into one common force, and we leveraged all that, I think, to try to make sure that this community was as protected. These people are our families, our friends, that they're as protected as they ever could be, regardless of where they are in the United States of America.
Dr. Kaufman, I'm not sure people realize how quickly you've pivoted in your role as a surgical oncologist. You were serving as interim chief medical officer. Our conversation we had in preparing for this, when I called him, he was actually about to walk into surgery. You're still actively practicing, and you are learning on the job not only about the pandemic, but you're an administrator now. So you're having to shift your focus from purely patient, I'm going to argue for my patient, as you said, to looking to the bigger picture. You seem calm, and when we spoke, I thought, he's walking into surgery, and you took time to visit. Would you share some of that? I mean, you've had to look at the hospital's bottom line. All of you are experiencing decrease in other revenue streams, and you've had to walk into a thicket.
Sure. So, shortly after the school closing statewide went into effect, it was clear that there was going to be a change, and there was a notice that a memo was circulating that they were going to be shutting down elective surgeries, which was done in other communities in other parts of the world and seemed like the reasonable thing to do. There had been a change in leadership at Lourdes, and there was no active CMO, and I knew the chief of staff there very well, and they were getting very busy, and it seemed like I was shortly going to be not as busy, and so I just casually mentioned that I was in a position to help from an administrative standpoint if I could share any of the burden that they need in regards to medical decision-making on the surgical platform, because I'd served as chief of staff for about a 4-year period when the hospital was built and then transitioned in the new campus, and part of that was developing a whole new sets of bylaws and rules and regulations, and so I was fairly familiar with all that. To my surprise, and definitely it was not my intent, was the way that I was told that I could best help the hospital was become an interim chief medical officer. And certainly by that time, the surgical volume was down. I was probably about half as busy as I was previously, and it seemed like a reasonable thing to do. But more importantly, I didn't feel like I could just sit on the sidelines while it was kind of evolved around me. Once I accepted that role, and then the information pathways that had been put into place, and the meetings and the phone calls, and then also everything coming from the FMOH system, it was literally like drinking from a fire hose. And I'm an information junkie, and boy, I was like a kid in a candy store. But like Amanda alluded to, a lot of bad information as well. Mm-hmm. And when you don't have time for formal studies and peer review and published articles, then you're trying to take as much anecdotal information from as many sources, try and filter out the junk, and then try and glean some nuggets from that information and try and predict what's going to happen and where you're going to be and what you're going to do. So that was a fascinating time. It was a very different role for me in regards to at least my day-to-day operations. And Amanda and Chuck and our fellow CMOs in the community were great about dragging me along and helping me out. I think we shared not only resources, but protocols and policies and procedures and, how are you guys doing this? And we're doing that. Hey, let me get you this protocol we came up with. And that was a huge time saver and efficiency thing that if one individual, for example, had developed a protocol for how we're going to deal with surgery during COVID, then that individual could share that across multiple hospitals and all the CMOs in the region, then we could use that moving forward. So yeah, there was a great cooperative atmosphere amongst all the physicians in the community and also all the institutions, not only with information but with resources, and that was
Right.
really, really, really nice to see.
So I guess you all agree that we should be wearing our mask all the time. There's no doubt. Now, Dr. Logue, you mentioned that, Lafayette General is about to undertake a vaccine trial. Are you able to discuss that with us?
Along the lines of research, I'm excited that with our partnership with Ochsner, it looks like we'll be initiating a vaccine trial for COVID here in Lafayette in about 4 weeks. We have a lot of details to work through between now and then. Most exciting thing about this one in particular so far is that it's a single dose as opposed to the 2 doses that are needed for all the other trials. So hoping that that will attract some interest. We're looking for a diverse population of people so that we can make sure that, as we've seen COVID proportionally affect different types of patients, we want to make sure that all of those patients are well represented in a trial so that when this is a phase 3 trial, when it's all concluded and able, if it's successful and able to go to market, that you can honestly step back and say we had a very diverse population that got it, and you can feel good about the outcomes that you see in each one of those so that we can better protect all of the members of our community. So yeah, we'll have more information coming out in the next few weeks about how to enroll, and there will be a lot of media announcements about that at that time.
So I've heard, on the news, of course, President Trump saying that a vaccine can be rolled out pretty quickly, but that's not typically how it works, right?
It's not typically how it works, and that goes back to the discussions around the phases, phase 1, 2, and 3. And there's a number of things that happen in those phases, and there's check marks along the way that are very necessary to say, are you producing something that is safe and efficacious along the way? Are you representing the right group of people? Are you biased? Do you have any bias in your research that would make the outcomes look better than they should be? And those stages are, there is some things under the federal government right now that are trying to facilitate those to go faster. But when it comes down to it, a phase 3 trial, for instance, needs to have the largest population of patients that you can get with the most diversity depending on the type of research trial you're doing. In this case, the largest group that you can get means the best data that you can come away with, saying we tested, and this trial is looking to test 60,000 people globally. They enrolled their first patient on Monday. So it's underway globally, but when you walk away with 60,000 people in a trial and you're able to say, less than 0.001% of people of all types that joined this, male, female, and all races, had a significant side effect. You have a lot more substantial information to go on, and the public and the healthcare workers can feel good about standing behind that information.
Okay. We've got about 10 minutes left with this panel. I'd like y'all to talk among yourselves about what you see coming up this fall. Are we in winter? Are we going to experience an uptick? You know how the flu season always seems to get worse as it gets cold. I don't know who wants to jump in, but what are you anticipating?
Dr. Logan and I had talked about this earlier, and I think one of the fears that we have is the dual pandemic, with influenza being part of that and COVID being the other part of that. We know from our friends down in the southern hemisphere in Australia that the COVID PPE in place for all the COVID that they're dealing with down there has greatly diminished the amount of influenza that they're seeing down there. And a lot of the comparative comments that we get from this, people, that I get from different people say, well, this thing is no worse than the flu. if you look at the numbers from the flu, well, if you think about the numbers from the flu, is people don't wear masks, they don't do proper hand washing, they're pretty much just out there doing what they want to do, traveling where they want to travel with no inhibition. And that was the numbers for the flu. When you look at COVID, which has been just largely protective with PPE, with rigid policy and whatnot in place, and yeah, it's not quite as bad as the flu, but watch what happens with the flu. I think the flu, if it holds true to form what's happened in Australia, I think the numbers in the United States, because of all the COVID protections in place, are going to significantly diminish. You know, we always every year wonder, is the flu vaccine going to work or not? Well, this year is not a great test year because there's going to be so much PPE out there that we won't really, it's not a fair comparison to previous years, you know? But that real fear of having dual pandemic, and I think all of us would echo that, is really the big question. And I think if we maintain the vigilance that we started with this thing, I think we'll get through the winter and the influenza pandemic okay. And you know, all of us, when we take our Hippocratic oath to practice medicine, the big thing that we focus on is to do no harm. And throughout this entire event, you know, that is the question that rings loud in all of our heads multiple times a day is what we're doing the right thing for our patients. And you know, like I said, it's a little bit like driving in a fog and really not knowing what's ahead, but by the same token, I personalize that a lot to say, is this what I would do for my own family, for my own children, for my own mother and father? And if this decision is okay, because we talk a lot about research and we talk a lot in the healthcare world about risk versus benefit. And when we look at these things, some of these decisions are not just a 99% versus 1. Some of these are 49-51 decisions that we're making, but we have to make those decisions. We also have to be able to put it in reverse very quickly should we make a wrong decision, because that do no harm, that is a constant, priority to us. So, but yeah, that is a fear I think all of us share is a dual pandemic, and it is a reality if we're not careful. But I think vigilance will get us through this next tough section. Hopefully we can move forward.
I think what's going to be interesting about this flu season is that there's a lot of overlap in symptoms. Not a lot, but there are definitely similar symptoms, the myalgias and the fever and things like that. And we're still struggling to have rapid testing that's reliable everywhere we need it. I mean, if it were a perfect world, we would have it in all the schools, right where you need it, point of care, be able to give you a rapid decision. That's just not the case. We're all still working on getting it wherever we need it at the right time. So if you can't tell the difference between whether you might have COVID or you might have flu, it would be, in years past, it would be great to think that when people have the flu, they truly isolate themselves so that they don't spread it. But we know that's not reality. But this year, people are worried enough about COVID that if there is a question about which one might I have, I think there's not only, in addition to, as Chuck said, all the PPE we wear all the time, but more isolation while you try to figure out what is it, and maybe wait on test results. That may mitigate the spread of it as well. I'm optimistic, hopeful, certainly, and I think when you talk about schools where those kids spread the flu a lot too, they will have to do that because they're not going to know the results of that COVID testing or that flu testing that rapidly sometimes.
Right. Predictive modeling and epidemiology have been really critical tools in how we're managing this and how we're predicting things in the future. Some of the best predictive models have come from Osterholm in Minnesota at the Epidemiology and Viral Center there. And the scenario that we've seen here in Louisiana and in other places has been fairly accurately predicted. And one unfortunately likely scenario, is of a third wave this winter. Every winter we get into in the hospitals what we call the respiratory season, or the fall flu season. And it's not only the flu, it's other respiratory illnesses. It's when our elderly populations come in with their pneumonias. And during that, at least locally here, November, December, January season, the hospitals are basically full even in non-COVID pandemic years. And resources and resource utilization become issues, and the ICUs get full. For a healthy hospital in the United States is currently running a 3% margin. That doesn't leave a whole lot of room for a huge amount of additional resources. We don't have 50 extra ICU beds. We now may have 50 extra ventilators. But you know, the scenario that we're in right now has been discussed for a long time, not necessarily for a novel virus, but if we get a really bad influenza strain one year, where we are right now with COVID and maybe in a much worse place was a very real phenomenon that a lot of people were worried about. Chuck is right on with the enhanced PPE and enhanced awareness of illness. There's been a dramatic decrease in the flu season in the Southern Hemisphere, both in the East and the West. I hope and I pray that that's going to be the case here, but I think that COVID fatigue is a very real thing, and this is the time where we need to maintain our awareness and our health and to keep doing what we're doing until hopefully we can get some successful vaccines in place. Once we get a vaccine in place, it's not going to be automatic. We can't let down our guard. It's going to take a tremendous amount of resources to get these vaccines out and distributed to the population to an extent where we can all be safe and get back to some semblance of normal again. So we definitely need to encourage the community. We're still at risk. The risk is very real, and it's not time to let our guard down just yet.
As we close, is there any thought that you'd each like to share that you thought I might be asking about? Is there anything that you didn't share that popped into your head? We each have about a minute maybe to close.
I mean, I think that we still have a long ways to go. I think that we typically, after you have an incident that you're going through, a natural disaster or something, you have sort of a debriefing afterwards and figure out what could we have done better. What do we want to learn for the next time we have to initiate something like that? I think that that's going to happen in terms of a national spectrum of healthcare. It's happening already in terms of what should we be doing differently, how should we be considering how we handle situations like this, how do we share information faster, how do we make sure that we have the right people giving the guidance out there and not filtering through misinformation. So I think that I'm very interested to watch the behavioral changes, the pressures that are going to be put upon healthcare systems in the way that we've traditionally done things, and certainly open to conversations about what is the right way to do it. I'm certainly not up here to say that we've got it all figured out. And I think this has shone a light on some of that. So I'm interested to see how we innovate coming out of this.
Thank you.
Dr. Kaufman and Dr. Logue had alluded to the fact that this vaccine, as we know, is not necessarily a panacea or a cure-all. And I think it's important from a community-focused standpoint to realize that this is not like we're going to switch a switch and things will be okay. I think just good, solid PPE and hygiene and those types of things are still core to everything we're doing. Probably the face mask is one of the most important things that we have to maintain. But even with a good flu vaccine on a good year, we're only looking at 50 to maybe 60% effectiveness of that. So if you think that the COVID vaccine, with the rapid process that it's gone through for approval, the main thing is we want to make sure it's safety. But the next thing is effectiveness, and we really don't know how that's going to pan out yet. And there's been a lot of focus on the media where people are, the vaccine is almost here, the vaccine is almost here. It's not like we're just going to switch this big switch on and everything's going to be okay. The effectiveness of the vaccine is one thing, the distribution of that is another thing, and plus the reality that the true effectiveness, even if it's a successful vaccine, might only be 50%. So I tell my employees, don't take your foot off the gas pedal, maintain vigilance, and we really need to focus on the long game here. And I know everybody's COVID weary, myself included, but this is really a long endurance race. It's not a sprint, and I would, little glimpses of hope are nice to look at, but I still think good core principles like we've been doing are really going to keep our communities safe.
Yeah, no, to echo what Chuck said, it's very possible, if not likely, that the best we're going to get out of a COVID vaccine is going to be a reduction in the severity of the disease and a reduction in the mortality. That means it's not going to keep you from getting the disease, and it's not going to keep you from getting sick, but it may lower your likelihood of succumbing or dying of the disease, and it may lower your likelihood of being hospitalized as a result. That's going to change things, and it is going to reduce the severity, but that's not going to be the effect in everybody. You know, we know from the influenza vaccine, it's not 100% effective. It certainly lowers your likelihood of having a severe illness. It lowers your likelihood of succumbing to disease, especially if you're older and have other comorbidities. But people still get the flu. I get the vaccine every year. I've had mild cases of the flu. And that's one of the recurring things that I get asked all the time by nurses and other team members is, do you get the flu vaccine? And if so, why should I get it? And the reason is because the flu vaccine morphs and changes every year. And I tell them what I'm doing is I'm building up a bank of immunity against the future. The same thing may be the case with COVID in that it's not going to be 100% effective. It's not going to keep you from getting COVID, but it's going to limit your need to access healthcare resources like the hospital, or maybe even, you can just take care of yourself with a little bit of, over-the-counter meds at home and not have to go into your primary care doctor, and also not be more likely to spread it and need other hospital resources. So, Chuck is absolutely 100% online on that, and that's something that we all need to be aware of.
I want to thank all of our panelists. I feel better now hearing behind the scenes what's going on, and you each bring such a trustworthy, just down-home message about what you're doing to take care of us. So would you please join me in thanking all of our esteemed panelists, Dr. Amanda Logue, Dr. Chuck Burnell, and Dr. Henry Kaufman.
Thank you.
And we are going to be queuing up Senator and Dr. Bill Cassidy in the next moment. So thank you. Thank you all for joining us. Sir.
you know, the life of a senator is very busy, and so we're waiting to get him queued up. So I thought I'd just come out, Jan, and just kind of let's do a little debrief about that amazing conversation. I was really enthralled with what they all had to say.
I didn't realize their thoughts on the vaccine. I knew that Dr. Logue was very excited about starting the trials, but even with that, we're gonna be wearing masks and self-protecting for quite a while, it sounds like. And it's hard to accept that for most of us. We're gonna have to be diligent.
Yeah, and I mean, I think though, when hearing about that they're looking at Australia as a test case because, you know, they're on opposite seasons, and
Yeah.
you know, if a mask keeps me safe from the flu as well. I had the flu, even though I got the flu shot, I got the flu last year, and it was awful. You know, I don't want to get the flu, so if a mask would keep me from getting the flu, much less COVID, I would definitely take that. You know, I was really struck with how communication was, they all talked about communication. Dr. Logue really talked about how it was important for communication among healthcare providers, that they all were working together. And then Chuck was talking about how communicating with his staff was important and how they got really creative with the videos. And then Henry was talking about communication with the patient. And, you know, a lot of people, they hear elective surgery, and yes, you think plastic surgery or something like that, but
It's
I mean,
not
those are like
necessarily.
serious
Yeah.
cases that are just, you know, they're important, but they're not that
Right.
level of urgency. And I thought that was just really interesting.
One thing we didn't get into that we'll get into as the panel, as the day goes on this morning, we didn't talk about telehealth because we were really getting an eagle's eye view from the heads of the hospitals and the head of Acadian Ambulance. But in fact, there's such a change going on throughout the whole healthcare industry, which I'm sure most of you know. And just so you know, I can't see any of you. Like the way the lighting is, I can't see any faces. So I can't tell what the reactions are, but everything is in a state of flux and things are changing so quickly that I think next year, whatever your discussion is going to be, we're going to look back at this and say, wow, we've learned so much about how quickly the health industry is changing.
I think so, absolutely. And I think, you know, it's just going to be, it's a phenomenal time to be in healthcare. And, you know, just, I love the analogy of the school bus and the fog. And I mean, you know, we're really all in this together. We're all on the school bus, whether we want to be or not. You know, we're all in this together. So, yeah.
Did I ask the questions you wanted me to? Was there something you were like, Jan, you should have asked this?
No, I think, like I said, I thought the information was really interesting. It's you know, there's like a public persona, or maybe like just, you watch I don't know if any of y'all remember the show ER or St. Elsewhere, and I'm definitely dating myself now, but you know, the real life is healthcare is not like a TV show. You know, it's there's real people really struggling, trying to figure it out, and really with this, they're really trying to figure it out as they go along.
Right.
And I'm just really grateful that we have such wonderful healthcare systems. We don't have just one system, we have two systems that really can come together. I don't know if everybody knows, both of our healthcare systems in the Acadiana area are not-for-profit. So Lafayette General is a community-owned not-for-profit. When it does merge with Auctioner, it will continue to be a non-for-profit. And then obviously Lourdes is operated by Franciscan Missionaries of Our Lady, which is also a nonprofit. So
Right.
when they talk about those profit margins of 3%, that's
Yeah.
razor thin.
Yeah.
Yeah, so are we?
Are we on?
We're still waiting, okay.
Yeah.
All right.
One thing I thought about, I don't know about the audience, but I've never been tested for COVID. You know, knock on wood, knock on my head. But I feel that the more time that's going by, you're better and better able to be treated more effectively and less invasively. And that's what they had shared with me, all of them on the phone calls, that they know so much now compared to the middle of March. And I'm sure we've all had friends and family and colleagues that have gotten COVID, and it's true what they say. There's a few people, of course, that had no pre-existing illnesses that still succumbed, but overall, it's how you present to the hospital. And it really is shining the light, I think, on the social determinants of health that Beacon works on. You're reaching out to people that may not be getting health care, that don't have a regular physician and don't have the resources to either get to the doctor or pay for their medication.
Yeah, and there's a lot of fear and misinformation still out there, and I think Dr. Logue, Amanda touched on that. You know, just part of what they're continually doing is combating that misinformation,
Right.
and you know, so, and I think we're going to hear more about that today as we talk about that. You know, a big component for all of us is health literacy. How literate are we? And it doesn't just mean like, do you know big fancy vocabulary words, but how well are you able to get information you need to make an informed decision about any kind of medical treatment? And so, you know, you said you haven't been COVID tested. I have been COVID tested. My husband had what ended up being a summer cold, but you know, there's always that uncertainty. We didn't know what he had, so he was able to be tested through his work. He works for a local hospital. He got a rapid test that came back negative, but they wanted to go ahead and do a longer test that was more accurate. So he got tested. I got tested through the testing sites that were set up over the summer at Cajun Field, which was a very easy, great experience. We both got our test results back at the same time. They were both negative. You know, but we quarantined at home for those few days, and you know, it was fine. It was a little, you know, you're always a little bit nervous as you're waiting on any kind of test results. But that was, you know, just the way. It's just the way. Keep going.
My daughter, I know we're waiting for Dr. Cassidy. My daughter is a senior at LSU, and so the big thing on campus is she's only got one class that she goes to once a week. Everything else is remote, which is really a drag for the kids, especially the seniors that are wanting to get that experience. But they had to test for the ability to get LSU football tickets, and even when they test, they don't know that they'll be able to receive tickets, but they're eligible. And they got their test results back. They were given free tests, and it took about, I think, 3 days, and she got her results back, which I thought was pretty quick, but it's not quick when you think you might have the disease. You know, she wasn't showing any signs of the disease. But what I wondered about, and we couldn't get into something like that on the panel in an hour, but if you test positive or negative, you don't really know. You hear about false positives and negatives, and you don't know that you might be exposed to it the next day. So I think all of our administrators in the hospitals, universities, school system are just doing the best they can with what they have. So
Yes.
it's going to be interesting.
Yeah, I think you know, as we just continue to grow and learn more, we're just going to continue to learn. One of the things that we really didn't get to touch on that I wish Dr. Burnell had been able to is the impact of Hurricane Laura on COVID.
Yeah, we didn't get into that.
We didn't even really kind of talk about that, but I think in some ways, you know, obviously Acadiana was spared a large part of the destruction. Unfortunately, our neighbors in Calcasieu, Cameron, Allen, Vernon, you know, those kind of parishes, Beauregard, you know, had tremendous amounts of damage, and so much so that the hospitals in Lake Charles were closed because of no electricity, no water, no sewer, and so many of those patients were evacuated over to the Lafayette, Acadiana area. And luckily, the COVID cases had declined enough that there was space in the hospital to accept them. But I remember, I think we talked to, maybe it was Dr. Logue, about how, you know, they went right back up to capacity again.
Right. Yeah, I've got through marriage, a family member from Lake Charles is in the hospital over here. They've all had to be relocated. So we're lucky that our hospitals, that we had all been practicing good hygiene and you know, safe practices. So
Yes. Yes, and then I don't know if anybody read the stories about there were about 20 or 30 babies in the Lake Charles NICU unit that had to be transported, and Acadian Ambulance was they were the transporters and transported all the babies over here and just being cared for. Beacon is working with several of these families, just as they transition. We're good. So I think that you have suffered enough under Jan and I just kind of taking it. So thank y'all for your patience as we got ready for Senator Bill Cassidy. I'm going to leave the stage, and Jan, if you want to just continue on your.
We'll run through and have a brief
We'll
intermission.
take a break as soon as Dr. Cassidy's done. Thank you.
Yeah. Well, please allow me to introduce U.S. Senator Bill Cassidy.
I'll try to drop.
That's okay. I have them.
Turn the volume down.
Senator Cassidy? Hi, Senator
We're live.
Cassidy.
We're live.
Hey, everybody. Senator Bill Cassidy here. I apologize being late. It seems a little bit something to say this, but I was on the call at the White House, and they're making a major announcement on healthcare today, and that's why I was not on the call. I apologize. But I can kind of address some of these concerns. Let me first say that the president's announcement today will attempt to make some significant changes as regards healthcare for the benefit of patients, particularly those who have less ability to afford their insurance, to afford healthcare in general, to afford their drugs. So I think it's positive, without knowing definitely what the president's going to be saying. I have had a tip of the hand as to what that might be. Before the election, to demonstrate his commitment to making sure that all Americans have access to health care, to make sure that those with pre-existing conditions have access to health care, as well as the tremendous support that has been given to healthcare providers throughout the COVID crisis. Now, in general, I'll just speak about what's the federal state of play right now, go into some of the things we're working on as regards telehealth and telemedicine, and then some of the priorities that are coming up. First, I think many in this audience probably benefited from the CARES packages that have already gone forth. The CARES packages had a lot of support for providers who, paradoxically, during the COVID crisis, ended up losing a lot of money. Everybody was sick, but nobody was coming to see the doctor unless they had COVID. And that, of course, ended up causing a revenue shortfall for many providers. So there is an attempt, by the way, for some of you who may have taken an advance payment on your Medicare. There has been some concerns on your Medicare fee-for-service. There have been some concerns as to the ability to get that money paid back. We will have a continuing resolution that passes probably next week in the Senate that addresses this, making the terms of repayment more lenient, stretching them out, lowering the interest rate. So if you are one of those who took that advance payment for fee-for-service, there will be some relief coming your way. I'd like to tell you there would be another CARES package coming before the election. I don't think that will be the case, partly because filling the Supreme Court seat is now going to take all the energy of the Congress, all the attention of the press, but also politics are up and we're close to the election. So I think if there is a next CARES package, which I personally advocate for, it'll occur after the election. In that case, those healthcare providers that continue to have a lingering negative effect of the economic shutdown, hopefully there'll be some relief there. Some folks in this room may have taken the payroll protection plan and are been affected by the supplemental payments for unemployment insurance. In the case of the latter, I know some healthcare providers that are unable to hire people because the $600 supplemental payment meant that folks were making more money on unemployment than they were working. I've heard from more than one healthcare provider regarding this. So first, as regards the PPP, there would be some attempt to address repayment status for those who took less than $150,000 from the initial payroll protection plan, perhaps even loan forgiveness, but certainly a kind of continuing to build upon the efforts to make it easier to repay, more understandable how to do so. Secondly, there could be a second payroll protection plan. There's been some industry that's been terribly hit. I think restaurants, for example, they're the best example. K. Paul's in New Orleans has closed its doors forever, an iconic restaurant. But there'll be other entities as well. One criteria that has been floated is that if the amount of money you received from a year ago to now has decreased by as much as 25%, then you would be possibly benefiting from the next payroll protection plan. Let me just briefly conclude, knowing that you have to stay on schedule. Telehealth, a lot of positive things were done with telehealth and telemental health. If you will, that may be a silver lining in the COVID crisis, putting more money and flexibility, which sped expansion. And so I do think those rules will be made permanent. I'm advocating for that as well. There's also going to be a big push by the administration to improve access for rural communities where clinics and hospitals might be far away. Last, end of year priorities. What can we do about surprise medical billing? I've already spoken about the president's initiative to lower healthcare costs, but there's pending legislation in Congress too. And then working on healthcare disparities. Maternal mortality, for example, women of color having higher mortality rates than others, particularly affecting us in Louisiana. What can we do about that? And then continued initiatives for chronic disease. COVID has clearly hit those with chronic diseases more than it has affected others. What can we do to address this? Well, I know you've got a program, and frankly, I'm supposed to be on another call already. I apologize for being on late. I thank you for all your good work. If there's anything we can do to serve you, please let us know. Thank you.
And I just want to point out, for those of you that may not know Senator Cassidy's background, he's dedicated his life, his professional life, to helping those in need. He's a graduate of LSU Medical School. He taught at the Earl K. Long Hospital, which was a hospital for the uninsured, and he co-founded the Greater Baton Rouge Community Clinic, which provided free dental and health care to the working uninsured. So he has really dedicated his life to helping us, and I'm glad we were able to make that call happen. And so now we're going to take a break until about 9:45, if that's still the schedule, Holly. We'll take a break for a few minutes if you want to walk around, and we'll start our second panel around that time. So.
Please welcome our host, Jan Swift, back to the stage.
Now I can see you. Thank you again for being with us today. I'm really looking forward to this session. It's about help or hinder, the impact of state and federal policy on our COVID response. And our first guest is going to join us is Senator Fred Mills. He's a licensed pharmacist and has served as the executive director for the Louisiana Board of Pharmacy. Senator Mills brings a sense of decency and intelligence to the public discussion on how we can best care for Louisiana's most vulnerable. To me, he's a friend, he's a colleague, and someone you can depend on to represent your interest. He's someone you can trust when you need an advocate. Please join me in welcoming Senator Fred Mills. The COVID days. You too.
Am I on, y'all?
I think you're on.
Good morning, everybody. Y'all okay with me taking my mask off? It's okay. First of all, thank you for having me. It's an absolute pleasure, and it's always a great, fun time to be with Jan. I guess I'll just start it off that Jan called a couple of weeks ago, and we started talking about certain things. We maybe wanted to recap of what we did last legislative session, COVID-19 policies, and how it affected the Health and Welfare Committee, which I'm chairman of. And from that conversation, things really have evolved into maybe something else I need to talk about at the first part. And that's where the legislature will be called into session on Monday at 6 o'clock. And the legislature has called themselves in session, not the governor calling us in, but the legislature. And I think a key point from the healthcare perspective is going to be basically one of the things, I think there's a group of legislators that basically want to open things up totally. And what they've been having is a petition out there that basically says that the governor's emergency powers would be revoked, and basically everything kind of opens back up, and it kind of comes back to the parishes to decide. There's a group of legislators that have said, no, that's not right. The governor is doing the right thing, and we totally support what he's doing from an emergency perspective. I think that is going to be a huge debate in the next couple of weeks, and I think you're going to see a lot of emotions versus science. I think you're going to see a lot of business interest versus the medical interest. I think you're going to see a tug of war between what the hospitals say that would happen from a capacity issue versus people are saying, you know, I can't make payroll because I'm working at a 25% capacity level. So I think you are going to see a tremendous amount of discourse, and you're going to see basically arguments on all sides. But for today, I guess we'll be talking more about COVID-19 policies. And from the standpoint that I've been seeing, I'm chairman of the Senate Health and Welfare Committee. And in the last legislative session, we as a committee made a decision that unless something was really timely and it needed to be acted on, that we decided not to have any legislation presented to our committee from the Senate side. We had 38 bills that had been filed. 18 legislators filed it and said, you know what, if we file this legislation and the Health and Welfare Committee has certain issues to discuss, it's not fair for the public not to be able to be there. And there were several issues that it concerned the nursing profession. And I was getting calls from nurses throughout the state of Louisiana saying, some of this will affect my profession, and I don't even have the capacity to be to Baton Rouge because there's so much going on. Now, this is in March. So just the backdrop, Jan, I'd like to lay for you is that you're going to see from a policy standpoint a really, really polarized debate. And we can talk more about it, but I just kind of wanted to set the table here.
Yeah. I know when we spoke, you said that really during the session there was money pouring into the state, but y'all were really focused on directing the money appropriately. But the opportunity for the public input was just not there for many reasons, and it makes it tough to lead like that when you don't get to hear from your constituents.
That's a great point. And you know, probably 40% of the 144 legislative members are new members. They've never been in the process. So still to this day, they've not seen a true debate in a committee hearing that has the input of all of the citizens and their special needs or their special interests. So it's a different dynamic because we've never had a normal session with the new legislators.
Right, and you can't vote by Zoom.
Now, you can't vote by Zoom, and what really troubled me was so many tough issues. If we don't have the public input, something is truly missing.
Yeah.
It really is.
I agree. Why don't we welcome Dr. Stefanski to join us? And let me get my notes here. Dr. Tina Stefanski is the Regional Medical Director for the Louisiana Department of Health in Acadiana. A Crowley native, she graduated from LSU Medical School and completed her residency in pediatrics. She's worked with the State of Louisiana Office of Public Health for the last 19 years. And as most of you know, she's been the voice of reason in Acadiana on how to manage and protect our health during this COVID pandemic. Dr. Stefanski, if you'll please join us.
Thank you. Good morning.
Yeah, thanks for being here today.
I appreciate being here. The
We did a
opportunity to be here.
podcast actually together, and we did it by phone.
Yes.
And I just prefer in person so much, even though we're a little bit afar, away from each other. I want to thank you for all the time you take, and if you can share with us what's been going on.
Sure, yes. Well, it's an honor to be here with all of you and to be on a panel with Senator Mills. I don't think the people of this region and certainly the state realize how fortunate we are to have someone of his intelligence and empathy and ability to reason. And so I personally think in this next session they need to vote to allow you to serve in perpetuity. I can't, perpetuity. We need you to remain in the legislature. Again, I appreciate the opportunity to be here and really, start off by thanking the healthcare professionals that are joining us, the members of the public, for all of their work over the last several months. We wouldn't be in the position that we're in today without the support and work of all of those, of this community and the people of this state, certainly our leaders, but also the general public. It's, I certainly understand that, asking people to really maintain these measures. So, it's not natural to us. Wearing face coverings aren't natural. We're people who like to get together. So not being able to congregate as we normally would, not being able to see members of your family, particularly those at high risk, are not easy things to do, and acknowledge that. And so I appreciate the opportunity to thank people for that work, because I feel like over these last several months was always, at a microphone talking about what we needed to do and how bad things could get. And so I'm happy to say that things are better, and you probably heard that on the last panel, that we're in a much better position that we were in, but it's not, but it's because of our, state and local leaders and the work of the public that we are where we are today.
Right. The last panel were all three doctors, and without fail, they emphasized the importance of keeping the mask on. And Dr. Stefanski, you've been preaching that.
Yes.
Do you feel like sometimes you need to hit us over the head with a 2x4 to drive those points home from a public health perspective?
Yes, certainly. And if you look at the graphs, if you look at our epi curves where we track and monitor cases over time, there is absolutely no doubt that the mask mandate has made a difference. And so again, when you track cases, we know that it's not reasonable to ask people to stay at home. Certainly that's effective, right? But that's not reasonable on many levels. It's not good for people's mental health. It's not good for their physical health. You saw Senator Cassidy say people often neglected other health issues, chronic health issues, because they were concerned about going to see a healthcare provider. So it's not good, certainly for the economy. So stay at home can't be something, is not something that's acceptable. So if we do want to continue to move forward, we're going to have to continue to do things like wear a mask, keep your hands clean, avoid big groups of people, and just being more careful and cautious over the next several months.
I'm curious, Senator Mills, when the legislation or when the legislators meet, I know you work closely with Dr. Stefanski. Is she going to be one of the witnesses that have to talk about the importance of keeping the mask mandate in place?
I hope not.
How do you interact? How do your offices interact between the Senate and Department of Health?
Jan, that's a great question, and I want to take this opportunity on behalf of all of Acadiana to thank Dr. Stefanski. You just would not realize the work that she's doing behind the scenes, because without her, we wouldn't be in this position. And from Dr. Stefanski's standpoint, she's juggling not only COVID-19, but when she sees me calling, she must say, it's him again, because I'm either calling about a water quality issue, I'm calling about a sewer issue, I'm calling about a permit. So you have that day-to-day work that the department still has to do, which is it's amazing what they regulate. But on top of that, you have the whole COVID-19 piece. Jen, you're right. We are going to have to bring in statistical information. We're going to have to bring in real data. And we are going to have to bring in healthcare experts, because what I think the debate is falling upon is, yes, we do have the economic debate, and I'm president of a bank, so my phone rings all day long of people saying, listen, I need a moratorium on my loan. I've been paying you guys out for the last 20 years. I'm at 25% capacity. I can't make a profit. So we're balancing that, and that's going to be where the debate's at. In my thoughts, what I'm hoping to see is the people that do this day to day saying, here's the facts. Now, can we balance, as Dr. Stefanski said, can we balance the economic portion with the healthcare portion? I feel we can. But we just can't lose that discipline that
Right.
the virus doesn't have a timeline.
Right.
You know?
No, and you know, it's also, it's a new virus. It's a pandemic. It's affecting the whole world, and we're all learning as we go. And so just as you might have heard from healthcare providers earlier on, that the treatment of the acute illness evolved over time. And so our physicians, our nurses are much better now at treating acute illness. So someone who, especially those who are hospitalized and acutely ill, you know, we've learned a lot about treatment, but there's still trials ongoing. So we still are working, you know, on what are the best ways to treat this virus. But similarly, what are the interventions, these we call non-pharmaceutical interventions, that the community needs to take in order to prevent or damper the spread of the virus? And there may not be a whole lot of evidence-based studies to prove that yet, because we're all learning again together. And so I do fear, or I'm concerned, that those individuals who are going to be on the kind of the extreme end, the other extreme, and want to open everything back up with no restrictions, no breaks, to say, you know, prove to us why we can't do this and why this wouldn't be a good thing. I think you're not going to find a whole lot of studies or evidence, because again we're learning, and so is the whole world. And so I would caution the public. While usually in medicine and science we say, let's look at evidence-based studies, let's study this and prove, you know, why are we making these decisions. In some cases there may not be a whole lot of great evidence other than what we've been through before. And so I can tell you, so in our Acadiana region, you know, the first wave, although we've never really probably gotten out of that first wave, we saw, when you compared us to New Orleans or the Houma Thibodeau area or even some of the northern parts of the state, we had a little bit of a bump, but we did not see those big increases in cases in the spring. However, we know over the summer, see that big increase. Our hospitals were really at capacity, and we had lots of people hospitalized and severely ill, and an increase in deaths. And we know that people were getting together. We know that the bars were a big driving factor in our community of that, and you know, not to pick on any one industry, but just people getting together in crowds and lowered inhibitions. And so as we are trying to do things more slowly and right this time, I really do hope that people recognize that that your actions right now are going to affect where this community can be economically in the next month or two. That if we don't continue to take things slow, while we may not have these great evidence-based studies, we certainly know what happened.
Right.
And Jan, one thought that's really interesting from kind of the political standpoint, and I think Dr. Stefanski can expand on it, but many of the calls and emails I get from constituents are basically questioning the actions of government and what's taking place, and it's maybe too restrictive, or why are you doing that, and there's a disconnect. But what's really interesting is right in March, the President's task force came up with a document called Open Up America Again. And in that document, it details what do you do in phase 1, what do you do in phase 2, what do you do in phase 3. And Louisiana and the healthcare experts in the governor's office have been following that really to the T. And Dr. Stefanski may talk more about it, because she met with Dr. Deborah Birx.
Yeah.
And they had those conversations. But when I tell constituents that we're pretty much following the federal guidelines of the Trump administration, I find the politics gets real crazy. It's kind of like, so a Democratic governor's following what a Republican administration's doing. I said, yeah, they're following it to the T. Yeah. And I find the public is kind of like, well, I wish I knew more of that. And we've been trying to just message from our office when I get calls is, here's the guidelines. They were developed in March, and the state is in a very methodical, disciplined way following it. And Tina may expand on it, Jan, to talk about your meeting with Dr.
Sure.
Burks, because I thought that was interesting,
Yeah.
you know, that type of situation.
Yeah, it was wonderful. I mean, that was definitely a highlight of these last several months was the opportunity to meet. You know, we had a great meeting with hospital representatives, you know, private healthcare providers, Dr. Burks, the governor, of course, our wonderful secretary of LDH, Dr. Phillips. And she praised Louisiana, praised the governor for following their guidance to a T, for frequent communications. And she mentioned that on the calls, our governor is often a voice of reason. And they were just, again, could not be more complimentary and about the fact that we as a state were following their guidance as intended. And so I do think that, like Fred said, probably a lot of people, you know, I suspect a lot of people don't realize that. And it's all, you know, we're all working towards the same goal. And so hopefully politics, you know, won't be something considered when people are thinking about what should or shouldn't happen in this next session, because it's science. And again, if we follow the guidance of the best health experts and scientists, then we, you know, that's all we really should or could be doing.
I'm glad the politics came up because you were reading my mind. And I laugh, Dr. Stefanski, when you took your oath, it wasn't, I promise to do no harm to Democrats or to Republicans, but this has become a political football. And from a physician standpoint and a pharmacist standpoint, you don't ask people when you treat them, how did you vote last time? You don't ask them anything except, what are your symptoms? How can I help you? And we're supposed to be talking about policy, but this digs so much deeper into some of us are hard-headed about who are we going to believe. And I think that's what I'm fearful of. I want to get into other policy, but with this session coming up, Louisiana is now one of the top states as far as the low level of infections, aren't we? We were
Yes.
Actually kind of brought out, saying, look at Louisiana, what they're doing, because we've been following the guidelines, and we could lose that so quickly.
Yeah, and I think it's great, I think leadership at the state level is so important, because consistently, if across the state we follow, we're all working again and moving in the same direction, and not letting each, and again, this is nothing to do with politics at all, but knowing that, we're geographically, it only makes sense, right? That that we all, again, are working and moving in the same direction and following the same guidance. That I think that's what got us out of the situation that we were in, where, frankly, again, when you look at the curves, when you look at the hospitalizations, I was really, really concerned with our hospitalizations, with our ICU admissions, with our ventilator usage, with this last kind of wave, or really our big increase in cases. I was very, very worried, knowing that all translated to individuals and their families and the repercussions. And so I do think it gets lost on the big scale that, you take it down to the individual personal level, and there are people that are still struggling with the after effects of this virus. And so it's important not to mix those politics up with people's health and their lives and the lives of their family, and then the health of our community.
I did a podcast recently that'll be aired, I think, next week with a fellow that helps treat people with addictions and mental health issues. And the evidence is looking to be that there are a lot more suicides this year than in the past. And I don't know how this falls into policy and what you see, both of you, but are you seeing an uptick in mental health challenges? Is that something you get statistics on in your office?
So no, I guess anecdotally, certainly I've heard that, but I don't have the data, the statistics nationally. Yes, all of those things are tracked, and this is definitely and across the world. On a few different levels. I think there's actually some concern about the virus and some of the things that we're learning about longer-term effects or near-term effects. On, we talk about heart disease and effects on the heart and muscle, your lungs, also neurologically, that this virus has some effects that we don't quite know about. And one is on mental health and cognition. So there's that. And then there's I think the whole anxiety, it causes a lot of anxiety for all of us. And then also the disconnection that in social isolation that people are feeling.
And Jan, just last week, it really came to a head from the legislative standpoint, the nursing home issue, to visit your loved ones in the nursing home. And I know the audience can probably relate to this so much, but the calls that we get as legislators is, look, I've not seen my grandmother in the nursing home since March, and we want to go and see her, and we've had enough. We just have had enough. And we had a conference call with Dr. Jimmy Guidry, the state health officer, and several healthcare experts that Dr. Stefanski works with. And I will tell you, it was one of the toughest calls we had. It was kind of like, let it all out, tell us what you got, tell us what your constituents want. And Dr. Guidry made a point. He said, listen, we are trying to balance out all of this, but I will tell you, if you go to the nursing home and you do even an outdoor visit and you hold hands with your loved ones, that spread can take off like this. And he said, I would much rather your loved one alive and go through this. And then CDC came up with the guidelines a few days later. What I saw in the call, though, I witnessed in the call, and I see in the call, it's Zoom now, so we do see each other on the call. The emotions were spilling over to the standpoint that my patience level is done. I can't take these calls anymore. I can't take the pressure anymore. And from, I guess, a politician standpoint, when you have an issue that's out there, and say it's a really polarizing issue, well, you probably get half of the calls for, half of the calls against. So you can kind of judge where's the pulse of where you should go from a policy standpoint. In this phase, every call we get is anger. So you take all of that anger, all of that frustration, businesses closing, people losing their jobs, musicians not being able to entertain. And I think the key I keep trying to say is, can we balance it? And Dr. Stefanski and LDH, I feel they do an excellent job. If we follow the protocols, we follow what we all know is the things we need to do as healthcare experts, I feel we can balance it. But that's becoming it's tough to fight emotions versus science.
Senator, do you think that with COVID highlighting how our vulnerable populations, are the nursing home issue is front and center, and you read my mind again, a lot of people want to stay in their homes as they age, and they need help, and a great number of our dollars, the state dollars that are, federal dollars coming in too, go to the nursing home industry. Do you think there's an opportunity for more in-depth discussion about looking at the policy that Louisiana has and maybe moving towards people being able to stay at home?
That's a huge issue, and I've seen it. This is my 13th year on the Health and Welfare Committee, and you do have that consistent battle of funding for long-term care. We can do both, but the nursing home industry does have a purpose of certain type of situations, and home health care does have a certain type of situation. That balance, I think, will always be a battle. You'll have the economic piece that's tugging at you, and then you're going to have the other piece that's basically, I want market share, so you're going to have that discussion. But I think in the immediate look at we have right now is we can't lose our focus on protecting that vulnerable population, no matter where they're located. And I find people are saying, and it rightfully so, is if mama doesn't get a touch from me and the family, that emotional distress is also killing her.
Yeah.
So it is one of the toughest situations I've seen from just political calls, because the public feels that we can, as legislators, kind of just make a call to Dr. Stefanski and it's done, and that's not how you handle this situation. It has to be policy driven.
You're not a magician.
What's that?
You're not a magician.
No. But we agree, and that's really been one of the toughest things over the last several months. And again, and it's back to, I know there are people who just want things to go back to normal. No one more than any of us, I'm sure. But I think it's trying to get people to reason with people and realize, the only expression I can think of is when the cat's out the bag, that's it. And so if we just don't take, this in we don't use a measured approach, then we're going to end up, we certainly could end up in a position where we're back to having to start shutting things down and to limiting things like nursing home, visitations that are just going to get ready to open back up, or schools opening back up, or businesses thankfully being able to do more. So the nursing homes has really been one, trying to explain to people, look, what our actions, as we're all healthy people in and about in the community, has a domino effect on the nursing homes. Because when the community, and so that's, when you talk about policy, that's one of the policies. And the governor, again, they consult with the White House on all of these. But, many decisions now being made tied to this percent positivity. So, when bars can reopen, and so in Lafayette, it was wonderful. The last couple of weeks we've had a low percent positivity, and so met the governor's criteria for bars to reopen. Similarly, CMS came out with guidelines that are tied to percent positivity in a parish for nursing home visitations outside and indoors. And so nursing homes are working really hard now. And some in our area have started the outdoor visitations. Indoor will be tied to percent positivity, but it's something that we're gonna have to monitor. Our nursing homes have done a tremendous job over the last couple of months to keep that population safe, because again, we saw what happens when this virus runs through a facility of just the most vulnerable individuals.
I thought our numbers would have shot up between Hurricane Laura, Labor Day, people going back to college and all, and we are maintaining,
Yes.
a good level of numbers. But how has Hurricane Laura, if y'all can talk among yourselves, maybe affected our health industry in this region in particular, and then maybe what we can anticipate from the state helping people recover?
Yeah, so I can, we've heard from healthcare providers that, as individuals, of course, have left Lake Charles, with lots of people, who are living in this area, and then, of course, the New Orleans and Baton Rouge region. But I know our hospitals, for those individuals who are starting to come back to Lake Charles, their healthcare system isn't up at capacity, and so they are. I do think that has affected that has had a little bit of an effect on our healthcare system here. And just from the state perspective and the federal, there has been support of those hospitals in Lake Charles through federal DMAT teams. Dr. Guidry, who Fred talked about, is wonderful. And again, from this region, from this area of the state. And so, he's been able to get some federal assistance to help support those healthcare, that healthcare system in the Lake Charles region. But it's going to take a while to come back up, so that will have an effect here.
And on an interesting note, taking just a little detour, one of the issues that was brought out to us is that for the special session, we'll need to address the funding for education for Hurricane Laura, because many of the students are now in Texas, and so we have to address TOPS.
And here.
Yes.
Yeah, but they're out of state is what you're
out of
saying.
state,
Yeah.
and so out of state, there's some funding issues, there's some issues that we have to look at, there's some issues if they would graduate in Texas, how it would affect TOPS. So there's several issues there. I know from talking to Dr. Guidry, and Dr. Stefanski knows this much better than me, is that I think the jury is still out with so many people living in hotel settings, living in the New Orleans area. And then I guess another issue too, I know Dr. Stefanski could probably expand on, is kind of what is the prediction coming up for the fall with flu season? Right. And also just from the standpoint of, I think, and so much of this audience can probably attest to it, just the wellness checkups, the taking care of yourself for routine visits. I think all of that Hurricane Laura, with so many people displaced and people needing surgeries that aren't maybe timely, but they'll be needed, I guess that would probably compound things, wouldn't you say, Don?
Yeah, definitely. And to go back to your question about Labor Day, same for us. We're monitoring, of course, all the time, but are looking for that big bump in Labor Day, and schools getting, coming back together. UL being back in, students being back on campus, and we haven't seen the big increases. And I really do think people in this community have, and when I talk to my counterparts across the state, it's not the same across the state. I do think people in this community have really remained faithful to wearing of masks and trying to be just a little bit more careful as we go out and about in public. And so I think if we can, again, not to beat a dead horse here, but if we can keep, I think once people see the benefit of an action, I'm hoping that will help to give us some evidence to continue this moving forward. And then, as Fred said, again, not a problem unique to us, but there were a lot of people who neglected their health, through this pandemic. And so we do want, and you probably heard that from Dr. Kaufman, You know, in addition to surgeries that had to be canceled because the healthcare system couldn't handle that capacity, including people who had cancer, whose surgeries had to be delayed if they weren't necessarily timely. Similarly, people with diabetes, hypertension, have frankly waited, in many cases, waited too long because they were scared or concerned about going to see their physician. Senator Cassidy talked about telemedicine. I mean, that's really been wonderful. But there are some things that people need to do in person, and we want to make sure that that's.
And a good point with a big issue I think is going to come about as telemedicine, and it may be of interest to the audience, but as telemedicine becomes more popular, a major issue nationwide is becoming parity of payment. And it's almost the standpoint that if it becomes more of a norm that a provider is paid equally to a regular visit, I think that's going to be a major issue that I think the healthcare profession probably needs to tackle. I met with the Medical Society a couple of weeks ago on a Zoom call, and I said that I think is kind of a prediction out there where the insurance carrier may say, well, here's a 50% reduction because it was telemedicine, and here's what you get for a home visit. So I think as it always comes about, money will probably be an issue to talk about.
Right. So during the early days of the COVID pandemic, I don't know where it is now, rules were suspended and telehealth visits were covered the same as in person. Where are they now, though? Are insurance companies not providing that? Do you know?
I'm not sure about the payment.
I'm not sure, but what I've heard, I've been on some national calls with the National Association of State Legislators, and they say that this is going to become a big issue that I think right now, because we're in a national emergency, that there's some relaxations of payment. But I think what I'm hearing is down the road, the insurance companies may deal with that, where I think the providers need to be on target to know that that could be an economic debate.
And you know, just thinking about it practically, when you're a provider, you're not going to, if you only get paid 50%, you're not just 50% liable if there's a problem with the patient. I mean, you're 100% there providing health care, which could be healthier than somebody driving to the office, being exposed to others. Or exposing others to what they have.
And you know, a big issue, as we kind of just kicking a lot of issues around with COVID-19 from the healthcare perspective to the economic perspective, you know, many physicians, many rural hospitals, because elective surgeries and because primary care wasn't delivered, a lot of these physicians and healthcare providers, their economic stream was really in a tough situation. So it's been an issue where I'm not sure full recovery has been there. You do have the PPP loans, you have those issues out there, but there's more than just certain facets of the economy that's been affected. It's also been the healthcare arena in some aspects.
And especially in Southwest Louisiana, I'm thinking of a personal story. My niece is a dentist, so they were closed for most of the past few months, had just really reopened, getting back on track, and then the hurricane came through. Her office is pretty much destroyed. Equipment's going to have to be replaced. And I don't know how people are going to bounce back, but we always seem to. We seem to have that spirit to bounce back.
And then the other issue, I think, is business owners and people that have healthcare practices. We still can't relax because you get a COVID outbreak in your office practice or in your pharmacy or in your clinic or whatever, and you lost your payroll. I mean, you lost your people that take care of the services day to day.
We spoke in the last panel about vaccines, and Lafayette General is going to be rolling out a trial with Ochsner and the desire to get this. Even if it's effective, they're saying it might be 50%. Nobody knows yet. But Senator Mills had brought up something with me, Dr. Stefanski, when we were preparing, and you said that there might be some legislation looked at because I don't know who is legally able to give shots. I know you can get some shots at the pharmacy, but this COVID vaccine, if we get it, we need to roll it out quickly, and it can't be handled by just doctors' offices and a few providers, right?
Right, and I'll let Dr. Stefanski be my safety net.
Is this a hot button?
Yeah. But I guess from the legislative standpoint, we have always, and a lot of this started with H1N1. When H1N1, we didn't know what we had to mobilize. Dr. Jimmy Guidry, the state health officer, called me up and he said, listen, are pharmacists and other professions ready to give immunizations? I said, yes, they've all been in training and they work under a collaborative practice type agreement. But to have individual authority, at that time, it wasn't existent. So he became very creative, and we opened up the spigots to allow more people to be able to give immunizations. What I have talked about with Louisiana Department of Health is that maybe we should, and we're looking at it right now, is give the agency more authority, that if they need to promulgate rules and regulations to make this specific to COVID-19 vaccinations, that certain maybe healthcare disciplines would be allowed to do certain things that are above and beyond their Practice Act, and maybe to have a little bit more independence. So that's something that we're probably going to be bringing out during the session, but it'll be kind of ironic to talk about it to give the administrative form of government more authority where there's a session to take away that authority. So we'll kind of talk about that policy, but I think Dr. Stefanski can probably talk more into that issue.
Sure, and so, you know, that's something that we do in public health is plan for distribution of, if we do have a pandemic or some other type of disaster, for the rapid distribution of an antiviral or an antibiotic or vaccine. And so those are plans that are always in the works, but when we talk about a vaccine, you can imagine how much more challenging that is to administer than an antibiotic or an antiviral that's, you know, in a pill form and in a bottle. And so I do think we're going to have to be more creative and innovative to, because of course we're going to want to rapidly deploy whatever, once we get a supply that's available and enough supply to administer to the community.
You think it's going to be a shot or a pill? Does anybody know?
It's a vaccine. It would be.
It has to be a shot.
Yeah. I mean, the formulations that I'm aware of at this point are.
I don't like shots.
And and then I've seen it year in and year out. When you do expand this opportunity, you are going to see a coalition of anti-vaccine folks.
Oh yeah.
They're very mobile and they are very vocal, and it's going to be another issue of the science isn't proven, the studies haven't been done, so you'll see a lot of that in the media.
May I piggyback on that? Speaking of vaccines, are you seeing a decline in children getting vaccinated?
Yes.
Like what's going on outside of this COVID stuff? Are people getting leery of vaccines?
Well, not so much that, but as we talked about, you know, people not wanting to access healthcare in person as much. That has been true for childhood immunizations as well. And so, you know, concerns, because it's, again, not just in the United States, this is worldwide. Again, it's, you know, there are great initiatives, you know, the Rotary Club, for example, these big polio, you know, helping to eliminate polio. So across the world, we're seeing a decrease in these routine immunizations, and that has got to quickly ramp back up because, you know, we're dealing with COVID right now, but we certainly know there are still these vaccine-preventable illnesses do still circulate more in other, you know, not so much in the United States, we have high immunization rates. So, so it is, you know, we really are working to try to get, you know, people back on track with vaccinations. And so school is another place. It's required for school entry in the state of Louisiana that a child be vaccinated and up to date on their immunizations. And so, you know, we know schools have been, you know, just kind of getting back, focusing on COVID. And so this is something that, as we're working to try to figure out flu vaccinations and COVID vaccinations maybe in the spring or summer, we also need to really push the routine immunizations for children.
Yeah, we've all been in hiding. I guess it's so easy to become lax in all of your health care, dental, everything. If you're not going out, you're not thinking like you would when you were just operating out in the world, you know.
Yeah, you know, we don't remember, thankfully, polio, but you know, my parents do. So that's a disease that still circulates in other parts of the world. And so I'm just choosing one. But you know, there are several. We still, of course, measles, mumps, rubella, pertussis. Those are diseases that occur in other parts of the world. We've been fortunate here. We don't see huge numbers of cases. Certainly not polio. We have not seen those cases here. But we do occasionally see little outbreaks or clusters of things like measles or mumps. And those are very real threats to the world if we don't, you know, kind of quickly pull together and step that up.
Dr. Stefanski, I know that the Department of Health does a lot more outside of COVID. And when we were preparing, water quality came up. And if you would explain, you do a lot more than just making sure people are wearing their mask. I mean, the big overview of your department, and maybe we can touch on water quality issues because I think we've got some real problems in our state.
Sure. So, you know, in the Louisiana Department of Health, we're an office under the department, the Office of Public Health. And so we've got this personal health side, so our health units. And so thanks to the taxpayers who greatly support the operations of our parish health units. We have our infectious disease and epidemiologist. That's kind of what you're thinking of with COVID. And then environmentally, our sanitarians inspect the restaurants that we eat in. Up to quarterly, just depends on on the numbers of individuals served through those restaurants, cafeterias, jails. We inspect all of those entities, but we also monitor drinking water. And so the EPA it's a safe drinking water program. So we monitor, we follow the EPA's guidelines for chemical contamination in your drinking water. So there's a schedule where we either sample or have to be assured that the system has sampled. And so we sample for chemical contamination, and then also for bacterial contamination, and that's done, of course, more routinely on a monthly basis. So yes, and so if there's a concern with a chemical or an element in the drinking water, we have to notify the drinking water system. Senator Mills is intimately aware of these issues, and so we work with constituents. With his constituents, with the general public all of the time, and so we have community water systems. In Lafayette, we've got LUS. You have people who live in mobile home parks. They may have a smaller community system, and so we have people who have individual water wells, and so we don't monitor those. So it's definitely a whole nother, as you said, function of our agency, but a really, really important one.
Poor Dr. Stefanski, I'm telling you, every time she sees my phone, it's about a water system. And we've had some behind-the-scenes meetings with angry residents of their water systems, and that's one of the biggest calls. And just to highlight that, I had a piece of legislation this session that I decided not to do because of COVID-19, but I really think we should have our water systems graded with a letter grade,
so
just like our school system. So if you get a notice that your water system got an F, there's different issues out there. And that's something I'm going to run with. But this is amazing, Jan. An independent engineer's report, engineering study shows from the last legislative audit that our entire water system infrastructure is rated a D-.
And why is that? Can you explain what they're looking at?
They have certain criteria, and Dr. Stefanski may know more about it, but I think it's the pipes and the testing,
aging,
and the aging of it and everything there. But just to get it from a D- to an acceptable level is a pin-up cost of over $5 billion. $5 billion. And I will tell you, there are so many water systems right now that are so old, and their infrastructure and their pumps and their whole system is so old. Dr. Stefanski and her team do as good a job as they can, but sometimes you're really putting a Band-Aid on something that has a cost that's so grave that you can't pass that on to your people that use the water system. So there's federal money, there's state money involved, but I would say this is going to be one of the biggest issues we'll be talking about for years is water quality.
And it's like, it's not blindsiding us, but I was listening to the radio the other day, and Aaron Brockovich was on Jim Inkster's show in Talk, Louisiana, and I didn't realize this was a big issue for us. We've been so focused on the pandemic, but we all know, like, whoever thought we'd be relying on bottled water when we were growing up, to have to buy water in a bottle. But what are we going to do? And people that don't have means, they're probably in the worst situations.
It's a huge issue, but I think the first issue is we have to bring it to the forefront. And I don't know how many of the audience gets one of those reports that maybe from the department that says, here's how many micrograms of this you got, and it's hard to understand that report. But everybody understands the way we grade our school systems. You understand an A-performing school and you understand an F-performing school. I truly believe that more transparency has to come to the homeowner to understand that at the end of the year, your system was graded an A, and that's great. But if your system's an F, here's the criteria for the F. And I think when the public sees that, it's going to demand a correction to it.
And it's not just us, it's nationally, right? It's probably an international problem. But
I don't know other states, but we are a D-.
And so, I want the public to know and to not panic, I guess, over this, because we do, if there's, we have levels of, there's so many chemicals that we monitor, and there's treatment. So, if you, and this is in elements, so this is where you need our engineers, and so I'm not going to talk a whole lot about the details because, again, I'm definitely not qualified to do that. But based on, so the EPA, we kind of have tiers of concern, right? And so if it rises to really, if there's really a significant, a known health concern, then the public or the individuals on that system are notified. And so if you haven't gotten that notice, we don't, and that doesn't happen often. We've been pretty fortunate. What it normally is kind of a push and pull between our engineers and the drinking water systems, looking at reports and what elements maybe that we need, that system can then treat for to help reduce that risk of exposure to individuals. And so it's, our engineers are on their A game. I mean, they're wonderful. It's a big part of the job that we do in public health is monitoring and ensuring that the drinking water that we've got is safe. But as Senator Mills said, at some point, these systems, we've got some aging systems, and so it's going to be costly, but it is something that we should all really be interested in.
So between COVID-19, polio, drinking water, I have complimentary Prozac for all of the audience.
Thank you.
When we leave. We're all going to take a Prozac and go home and just...
From Cashway Pharmacy.
Quit it. Sorry, Jan.
And I really, so, I do think, hopefully people take away from this that the role of government is important. And so, we need to have some entity, when talking about drinking water, who has no stake in the game other than to make sure that the water that we drink is safe and healthy. So,
right. I'm thinking when people get a call, this is the government, and I'm
exactly.
here to help you. Nobody's really that excited, but boy, do we depend on you guys. We can't fix this. Like a consumer on our own, we cannot fix the water system.
There was a neighborhood in this area that after a big rain, the water system was totally messed up, and sewer was coming out of people's tubs.
Oh, God.
And that's when you want some government.
Yeah.
You want some government.
Now.
When sewer's coming out of your tub, you want government. And that's where immediately I called Dr. Stefanski, and we get a team of her engineers together. We get the people that maybe own the system. We get the people that use the water system, and we have a pretty tough meeting, and they demand corrective action.
Yeah.
They do a fabulous job, but I always tell people, you want some government in that situation.
Yeah. After Hurricane Laura and Lake Charles again, some people were getting their lights back on, but the water was, it's still an issue. And so you can't live in a community if you don't have safe or accessible water. And talk about not even washing your hands, but just having to boil everything to bathe. It's, we take all this for granted.
Yes, we do.
What was told to me, and Dr. Stefanski can maybe back that up, but in some of the smaller rural areas that were highly affected from the hurricane, that just, they don't have much resources, because we hear about the Calcasieu and Cameron a lot. The trees were uprooted in such a drastic way that the piping of the water systems were removed from the ground.
Oh, gosh.
So not only do they have to get their pumps and system back, the infrastructure has to be rebuilt. So it's pretty tough.
Yeah, absolutely.
You don't go into Southwest. You're not in Calcasieu. You're region.
Acadiana. So really, Acadia Parish is for West.
Yeah.
Which happens to be where I'm from.
Right.
Not to mention Acadia.
I forgot the Stefanski family in Crowley. Yeah. We've got a few minutes. Is there something you'd like to ask each other that you were curious that we might talk about? Can I put you on the spot?
Well, I would just like to ask Senator Mills to stay in his position, but I know he can't.
I guess pretty much not ask, but I guess, Tina, why don't you, because I think this would be interesting, why don't you talk about some of the calls you get, not COVID-19 related, but some of the vast array of topics that hit your department. I think it's really interesting. I see it as a legislator, and I was just amazed at the calls I would get that came across your department and the skill set that your people have. Why don't you talk a little bit about, in a typical non-COVID day, what's some of the issues that your department tackles?
Sure, I certainly think environmental, those are some of the toughest, the environmental concerns. People who live in a community or in a neighborhood, and the sewer system, for example, was really not up to par. And the developer left, and these people are sitting there struggling and trying to figure out. I mean, as you said, when you have sewer coming up through through surfaces in your home, that's a huge problem. And so that's one, that again takes a lot of work, a lot of effort. That's when, over the years we've worked with Lafayette Consolidated Government, just thinking of a few examples, and they've actually had to take over systems, sewer systems, to try to get things up to par and help a community. But all of that does not happen quickly. There's a big process to that. I think TB is another issue. We take a lot of this for granted, and like Senator Mills said, I hate to talk about all these things that we don't want to depress y'all, but I guess hopefully you know that there is actually work and people looking to for the greater interests. So working with TB patients or people who aren't compliant with their medication, and what they do affects the community. And again, working with providers, with physicians, with hospitals. To make sure that it takes a village with some of these issues to make sure that that one person is cared for and taking their medication and doing what they need to do, so that it then protects all of us. It's very interesting when people evacuate for a disaster. We track all of those kinds of things to make sure that those patients are accounted for, have the medication that they need, and that we're actually witnessing them taking their medication. Those are some of the things that I think people don't think about or realize. We for mold, people concerned about mold in a school or in a community, a place where the community might visit, and they're worried about their exposures. So again, working with our environmental health guys.
Since you mentioned schools, and we're going to be wrapping up, your office gives guidance to the schools, right? The universities and all. I wanted to get that in, that people are given direction from your office as to how they need to operate once the schools have reopened,
a lot
besides
of guidance.
businesses.
I've never, ever talked to schools superintendent as much as we have over the last couple of weeks, and it's a good thing. And again, I'll tell you, so for example, the numbers were released yesterday, the numbers in K through 12 cases around the state. And so we were, the highest number, Baton Rouge was right behind us. They had, I think, one less than us. But it's because our schools, and so I went in and, I see all these reports, and I had looked, and I had already brought it up to our epidemiologists at the state level to say, hey, look, I'm looking at these reports, and our schools are reporting better than any place else in the state. And so you see those things. So just for anyone who noticed that our numbers were bigger than other parts of the state, we have phenomenal. Our schools are really following our guidance, and same for UL. They have just been incredible and are doing a tremendous job to again keep kids and faculty as safe as they can while they're there on campus. Yeah.
This was a pleasure. Thanks for
It
having me.
was. You didn't get to tell any jokes or do any
I
of your
know.
funny
Next time we're going to get
bits.
together, we're just going to laugh, because I got all kind of jokes I can tell you, and all kind of crazy stories I can.
He's
I
really
can
got
tell
some
you.
stories.
I will
I
tell
know.
you, it was amazing the people that called me up to know where they could get Clorox to take
Oh, no.
after the interview. People there like, T. Fred, where can I get some Clorox for COVID-19? I was there. Don't go get Clorox. Don't go get Clorox. So
Just use it to clean.
Yeah, just use it to clean.
So dispel that rumor that is not
Yeah.
effective to prevent COVID.
But thank you, healthcare professionals. There's so many of you that
Yes.
the success is because of you, and thank you so much.
Yeah.
Yes,
Did you have something else?
No, I mean, just to say the healthcare professionals who are caring for patients, it's scary. It's concerning for people. You don't know. I mean, it's not just COVID. I mean, but certainly with COVID, as we're still learning about transmission and presentation, people are putting their lives and their families' lives at risk when they go to work and in a provider's office or in a hospital. I mean, it really is not to overstate. I mean, it really is a tremendous profession, and we really have a great group of healthcare providers here.
I want to thank you both. Senator Fred Mills, such a pleasure, and
Yes.
Dr. Tina Stefanski.
thank you.
I love that we're getting to know each other better, and thank you for taking time today. And we are now going to take another short break, and we will be focusing on improving population health during and after a pandemic. So thank you all. We'll take a short break.
Thank y'all.
Thanks.
Thank y'all.
Thank you.
Jen, thanks for having me.
Oh, my goodness.
Your mind, yeah,
We'd like to welcome back Dr. Holly Howitt and Jan Swift back to the stage, please.
All right, so welcome back. In our last session, well, excuse me, our almost last session, we'll be ending today with Cian Robinson. We're going to talk now about improving population health during and after a pandemic. And this will be the first time I've done something that's all virtual. We'll be having our guest panelist virtual, so you'll be experiencing this with us. Our first guest is Dr. Sandra Brown. She serves as Dean of the College of Nursing and Allied Health at Southern University in Baton Rouge. She also chairs Governor John Bel Edwards' COVID-19 Health Equity Task Force. Dr. Brown has more than 31 years of experience in the field of nursing, having earned a doctoral degree in nursing science from LSU Medical Center. And I do want to say as an aside that Southern School of Nursing was created in 1985, and it's one of the top producers of undergraduate baccalaureate degrees awarded in nursing to African Americans in the U.S., which we should all be proud of. Dr. Sandra Brown, welcome to our panel.
Thank you. Hello. Can you all see me?
Yes. Good morning.
Hello, everyone. It's a pleasure to be here, and I'm grateful to be here with the panelists. Do you want me to get started with the slide presentation?
Please. Yes.
Okay. All this technology.
I know.
It was just up there a minute ago.
There we go.
Can you all see this? Yes. Okay, great.
There you go.
I thought a fitting title for this presentation would be COVID-19 and Health Disparities, a Crisis Within a Crisis, because that is exactly what we are experiencing. I'd like to start with our Louisiana health rankings. Louisiana, unfortunately, ranks 49th in the nation as one of the least healthiest states. We also have very poor rankings as it relates to our prevalence of diabetes and cardiovascular disease and obesity. And we're the third highest state in the nation for our poverty rate. We have held this ranking for some time now. This is nothing new. We flip-flop with our neighboring state, Mississippi. One year they're 49th or 50th, and then one year Louisiana is. So these rankings we've held for decades. When we talk about health disparities in Louisiana, when you look at the chronic illnesses I just mentioned, and add that to low socioeconomic status and barriers to accessing quality health care, it's going to yield poor health outcomes and perpetuate health inequities. So when we talk about health disparities in Louisiana, this is the very simple formula that we're faced with. We cannot talk about health disparities without looking at health equity versus health inequity. So health equity means that everyone has the same opportunity to attain their highest level of health, whereas health inequity, it stems from generations of African Americans who've not had access to resources to obtain that same level of quality health care. So how has COVID-19 impacted Louisiana? What it has done, it has put racial health disparities and economic inequities in the spotlight, of which Louisiana can no longer ignore. We applaud Governor John Bel Edwards for appointing the Louisiana COVID-19 Health Equity Task Force. He heard our voices and he took action, because early in April, we were facing a huge disproportionate allocation of the COVID-19 impact on African Americans. So he appointed a COVID-19 Health Equity Task Force. I serve as co-chair of it, and my partnering co-chair is Dr. Thomas Levis, who is the dean of the School of Public Health at Tulane. The COVID-19 Health Equity Task Force is comprised of over 50 members of subject matter experts from across the state of Louisiana. And so our charge was very simple. It was to provide recommendations relative to health inequities. We were to provide reliable data as it relates to COVID-19, and we were to develop a statewide dashboard on health equity. We look at this as an opportunity to not only address COVID-19, but to take a deeper dive into real-time interventions that we could use and take real action. And so the task force came up with 9 priority areas. Our first priority area, of course, had to relate with testing for vulnerable and at-risk populations. We wanted to ensure that anyone and everyone who wanted to be tested could be, and that there would be no charge. And we encouraged the removal of those barriers, and that those testing strategies would be strategically located in communities where vulnerable populations were most impacted. And we also emphasize adding testing strategies for our frontline workers. Communications and messaging, this is the subcommittee that's looking at getting our message out. We know that the messenger is just as important as the message, and the messenger has to be relatable, reliable, and trustworthy, because public health is built on public trust. And so we're using some strategies, all the social media platforms and billboards, digital billboards, to get our messaging out about proper wearing of the mask, about myths as it relates to COVID-19. Our data and analysis subcommittee has looked at data that has been provided to us by LDH. One of the things that we noticed early on, that there were gaps in the data. We wanted to receive data based on zip codes, because we know that a person's zip code is more important than their genetic code, because where you live should not determine whether you live. And if we could take a deeper dive into where the zip codes were most vulnerable, then we could target some populations that we could reach. We also wanted to ensure that the data was accurate, because accurate data gives us an opportunity whether to loosen up or open up restrictions, and faulty data is worse than no data at all. The Health Equity Dashboard, this committee recommended key elements that were going to go into the dashboard, looking at social determinants of health. We're going to house that Health Equity Dashboard at LDH Equity website. It's being built. We're looking at social determinants of health and political determinants of health. We've also looked at other states and what they're doing, how their health equity dashboards are devised, and learning best practices, and still holding on to the nuances that makes Louisiana so unique. So this health equity dashboard, we're hoping that it will be engaging, and that it'll be real time and accessible anytime, anywhere, using mobile devices. We also thought it was important to look at special populations. Louisiana prisons was one of our populations. We wanted to make sure that the state was doing what they were obliged to do, and that CDC regulations were being adhered to in that population. Nursing homes was another area that we looked at as far as vulnerable populations. Early on, we realized that over 40% of the deaths that occur in the state of Louisiana have occurred in nursing homes. So we wanted to make sure that a strategic, comprehensive plan was in place to protect the residents of the nursing homes. Policy and Regulatory Affairs Committee, this is the committee that is going to recommend to state legislature different aspects as it relates to access of care, discrimination. We know that the country is facing 3 epidemics right now. We have a economic pandemic going on, we have a physiologic pandemic, and a sociologic pandemic. And all of those pandemics are coalescing at the same time. The community outreach and stakeholder engagement is looking at grassroots level, identifying platforms that we can increase community engagement as it relates to COVID-19. Who better to tell their story than the individuals who have lived it? And our last priority area is racial disparities in healthcare. That subcommittee is looking at our crisis of care manual. That manual is our go-to manual when a crisis occurs in the state. Well, that manual is over 10 years old. So that committee is making updated recommendations. And they're also looking at medical mistrust and biases that occur among our citizens in Louisiana. So those are our priority areas. We've met with other health equity task forces. We're forming coalitions with other health equity task forces throughout the United States. We're not too proud to learn what works for them that we could apply here in Louisiana. When we started this task force, we had no real blueprint, just a group of dedicated individuals who were committed to making meaningful change for our citizens. We know that this is a movement, it's not a moment, and that we've got to use this crisis to make a difference for generations to come. We're not satisfied with being 49th in the nation as the least healthiest state, and we cannot go back to status quo because everything has changed. 2020 is the year that has changed the world. Thank you. You can also access the full recommendations of our 9 priority areas of the Health Equity Task Force by visiting www.sus.edu. That stands for Southern University System. And you can email me directly if you have any further questions. Thank you so much.
Thank you, Dr. Brown. Hold on with us. We're going to have a couple more speakers, and then we'll allow all of you to speak together and maybe share some notes. I'd like to welcome our next guest, Ryan Bosch, founder of Socially Determined, a Washington, D.C.-based technology platform that integrates knowledge of the social determinants of health with clinical data through advanced analytics. Their mission is to better understand the impact of the social determinants of health to thereby improve the health of millions of people. Ryan is a graduate of the University of Virginia School of Medicine. He attended school on a U.S. Air Force scholarship. He earned an MBA in healthcare informatics from George Washington University. Dr. Bosch? He's not here? Okay. Is Dr. Brown? You think Dr. Brown can hear us? Okay. And we are ready? Okay. While we're working on our connection, I'd like to welcome Dr. Iris Malone, a family nurse practitioner with Our Lady of Lourdes. Dr. Malone earned a doctorate in nursing practice from the University of Alabama. She also oversees primary care services to students and faculty at Northside High School Health Center, a school-based health clinic, which is a collaboration between Our Lady of Lourdes and the Lafayette Parish School Board. This center provides free healthcare services to students and staff in the 70501 zip code, an area deemed high risk for health issues. Dr. Malone, are you with us?
Yes.
Yes, good morning.
Good
this
morning,
is Jan.
everyone.
Hi. Good morning. Thank you for joining us.
Sure, you're welcome. So there's always a ram in the bush, right?
Yep.
I come on and save the day. So I am going to speak on my personal experience as a primary care provider and also with working among adolescents and with the school-based health center. I'm going to tag on a little bit to what Dr. Brown had mentioned in her presentation, because there is so much that that's going on for the year of 2020. And as she says, is a movement and not a moment. And So I will speak to my experience about that particular concept, because I want to know for sure, is it truly a movement and not a moment? And are we just caught up in the hype of it all? Of course, we have known and health inequity for quite a long time. We talk about the different communities that we serve. We know that that low socioeconomic income families are the ones that suffer the most or have the most health issues. But then I start looking at, and I wonder if some of that is basically true, or is it a cultural thing? I don't know. I've been brainstorming over the last few months. And I look at the fact, and I have a PowerPoint, so my eyes is not going cross. I'm just going back and forth, okay? Because I know I was trying to share it, but if we're not able to share my screen, that's fine. So I just want you to follow along with me. In regards to health insurance, we always say that there's limited access to health insurance or healthcare providers that can care for those most in need. Part of that is true, but in the community that I serve is heavily Medicaid, so they have access, or they have the ability to have the insurance, and some of them have access to providers. But what I find is that sometimes we do not understand how to communicate in a culturally sensitive way with our patients. Sometimes they'll leave the provider's office, and I get this a lot in just with my church home, my church members, and the people who we do health fairs and those types of things with. And they will come from the doctor's office, literally sometimes, straight to me and ask me the questions about what they heard from their provider, because they didn't understand what was being told to them. And so, sometimes it's a shame for you to have, this insurance, and you have your provider explaining things to you, but then at the same time, you're still not understanding, and you're missing some of the important piece of how to care for yourself. And so I find that a lot when we talk about health insurance coverage, that with the Affordable Care Act, that we do have people with health insurance. But yet, like I said, that the health providers, I don't find that we're doing a great job of educating our people in a way that they can understand. So guardian and family health literacy is another barrier to care. We have families who will probably learn how to communicate with each other about what they understand. And so they'll explain it to their family member. And I find that, especially among certain cultures, African-American culture, that we hear what the other person is saying. We hear what our peers and our friends and our neighbors are telling us about what we should do, even though intellectually we learn about certain things. But at the same time, if my neighbor or my friend says, I heard that if you do this or if you take that, that'll work better for you. So I find that it becomes more of a sharing of ideas among a social group. And I'm not sure that's considered illiterate. I just think that we trust what we say among our family and our friends. I had a student one time, and here I'm telling her she needs to increase her water intake. She needs to make sure that she eats healthy. Well, she says, okay, that's fine, because she's come to me with several times. She's had bladder infections and so on and so forth. So I usually ask them, do you have water? Because we always say drink more bottled water. Well, of course, she didn't have bottled water, so I told her how to be able to take water from the faucet at her home, put a pot on the stove, boil the water, and then now you have good, clean water. So she took my idea and she said, okay, that's fine. Then I said, well, are you drinking more water? Well, no, I'm not drinking more water. Why? She says, well, we don't really have water in the home. She's found out that she has to go underneath her house to be able to turn on the water faucet because the water was turned off. So then I bought her a container where she can boil the water, put the water in a container, and put the water in a refrigerator. It has like a little spout on it. So she took that idea and she says, well, my mother loves it so much that she's using it to wash her hair. So she uses it like a sink, and she puts her head on it and she starts washing her hair with a little water faucet. I'm saying all of that to say, you know, even though we explain things to our patients, we have to be able to dive a little bit deeper into what they have available to them, and don't assume that they have access to these things because we're living in modern day time. It may not always be that way. So that our home environment plays a big piece into how, you know, into the barriers to care. Unreliable transportation. We all know that transportation is an issue. Many people ride the bus. They can't have access to getting to the bus on time. I've had students where providers, specialty providers, have dropped them from the care. Now, granted, they have limited access, especially to specialists. Well, they dropped them from the care because the patient was unable to get to their office in a timely manner, or that they missed appointments. I've had to, on a few occasions, these were students with heart issues who had open heart surgery, who's come to me during school time and saying, I'm having chest pain. Well, as a limited provider in a healthcare setting, I'm not their primary care provider, but then yet I got to do that case management piece to be able to find someone who accepts Medicaid to get that child the care that they need. So transportation becomes more of an issue than just getting on the bus. Providers are dropping them from their care because they're not keeping up with these types of appointments. Make a long story short, I met that same student working in Walmart after she graduated. She told me that she had fainted on the job because she went into atrial fibrillation. She ended up having a pacemaker put in. And that's how she's doing today. But she appreciated the fact that I was able to connect her and get her the care she needs, and beg the provider to be able to take another student with limited health care and limited access to specialty care. Prior experience that creates lack of trust in the healthcare is another barrier. We all know that sometimes we don't trust our, the primary care providers, either because they're not explaining things correctly to where I can understand, or they're running us out of our office because they have yet to get to the next patient. And I've heard that a lot. I don't understand what so-and-so is saying, what the doctor is telling me. Or I don't understand, they seem like they're not taking their time with me and that they don't care about me anyway. So, I don't really trust what they're telling me. Cultural competency, lack of healthcare provider training. We as providers need to become more culturally sensitive. And I think that that's one of the big issues. You can be an African-American physician, but that doesn't, or a healthcare provider, doesn't mean that you still understand how to be able to communicate with your particular patient. And let's go down to this. Excuse me, I'll get to the next slide here. And so, what can we do in regards to health equity? We know that there's longstanding systemic health and social inequities. They have contributed to racial and ethnic minority populations being disproportionately affected by the health issues. We need to be able to hold those candid conversations, as we always say. But sometimes that's getting out of our comfort zone, which I'm beginning to be more comfortable with sharing my experiences as an African-American primary care provider. It was kind of difficult at one time because we didn't know for sure how our patients would accept it, how our coworkers and peers would accept our conversations that we have. But we all have these challenges as providers to be able to understand our patients, to be able to work among our other peers and share those candid conversations to say, really, we need to be able to, and then also too, when it comes down to health disparities, what can we do? Of course, we can work together. I'm a nurse practitioner. I have tried on occasions to be able to communicate with primary care providers. Some of them see it as some type of stealing their patients. But when I find things on patients that these students were not assessed for whatever reason, many of my students that I see, when I refer them back to their primary care provider because I found lumps in their brain. I've had some patients to say, some of the students to say, well, my doctor never even touched me. You know, I said they never did a physical examination. Did they listen to you? I had that with the mother or the parent, and they did not. She said, I've never had my child to have an actual physical examination, a comprehensive physical exam. So again, I try, you know, my best to work with other primary care providers to share the types of things that I do with the school-based health center, to be able to say, let's work together and let's share, making sure that that student gets the total type of care. If I find one thing, I will definitely tell you so that you can continue to give that child the care that they need. Some of them accept it in a welcome way, and some of them think that, again, I'm stealing their patients. I think that if, as a community, if we collaborate with doing health fairs and health expos, is all great, but it's the follow-up that's the most important thing. Is the surveys as to say why, when your blood pressure is 200 over 180, you haven't been taking your medications. Are you on medications? Why are you not taking the medications? Many community members, many participants in the health expos and health fairs have said, you know, I'll take my apple cider vinegar, or I'll deal with that when the time comes. Many of them use the emergency rooms as their primary care provider. They have insurance, they have providers, but yet they go to the emergency room because when they feel it, that's when they'll, you know, that's when it means more to them. So I think we need to have these conversations with our patients, understand the culture, understand that there's, from these health, to be able to have care providers that look like us, that can communicate, that can relate more to our patients and our students. And that is my part of the conversation.
Thank you, Dr. Iris Malone. And I think now we're ready to queue up, are we right, for Dr. Ryan Bosch. Dr. Bosch, we introduced you a while ago. I thought you were on our Zoom call. Ryan Bosch is founder of Socially Determined. He's out of Washington, D.C., and he's going to share with us their technology that they use to identify these social determinants of health we've been speaking about. So we're really looking forward to hearing your message, Dr. Bosch.
Thank you, Jan and Holly, and hopefully my sound is coming through okay.
I think so. Yep.
Excellent. You know, it's a little bit of a helpless feeling to hear your introduction before, but to not be able to do anything but see it on TV as I was following the live stream. So thank you for your patience now that we've got this technical difficulty fixed here. I wanted to share my screen, if that was all right with the group, for folks in the room to be able to follow the slides. Jan and Holly, are you able to see those?
Yes. Thank you.
Super, super. So again, good morning. Thank you very much for having me. My name is Ryan Bosch. I'm an internal medicine doctor, trained in the military, grew up as a public health officer, and really appreciate the comments in session 1, session 2, and also here by my co-panelists, Dr. Malone and Iris Malone, or Dr. Brown, I'm sorry, excuse me. I wanted to start here with the question that was put forth, and that was, how do we predict high-risk individuals and proactively identify health issues, particularly related to this pandemic that sits before us. In my personal experience as an internal medicine doctor, people look at us, all of us as panelists here, as providers. But I want to ask the group at home and in person there to think about this at scale, to think about this as groups. I will circle back to the individual social needs of a patient as that affects their clinical outcomes and their utilization. But I want to make sure that as you view my comments in this discussion, before we get into our broader panel discussion, that you think about this at scale, looking at the demand, the common view of risk, to understand what are those social factors that affect the clinical factors, thus affecting outcomes. And those outcomes can vary from cost outcomes, care outcomes, health outcomes, and ultimately outcomes around the community wellness. So first, from a technology standpoint, what I advocate for, and my company has been involved in multiple partnerships around, is establishing a common view of risk. And that goes right back to the fundamentals of knowing your customers, knowing your communities, and then knowing what resources you have, so that at scale you can deliver precise and effective care. So what are the steps for that? What does that really mean? Well, among a pandemic that we have now, I don't need to convince this group. I've learned and listened all morning about the impact that social risk has as a driver for health, for access to care, for the access to clean water, for access to transportation, for health literacy around what conditions need care and what conditions might be able to be set aside for a period of time during the pandemic. And then also I want to recognize the underpinnings of the pandemic clearly affects certain comorbidities, the tendency for a touch of sugar, as some of my patients would call it, to have diabetes or the sugar or pre-diabetes. These conditions, also asthma and heart failure, significantly contribute towards risk of COVID. So if we're going to improve outcomes and match resource allocations at scale, we need a way to do this. So we've established and seen through different work with our partners is establishing different social determinants of health risk levels. So levels within the community, levels at the individual longitudinal sense, and then levels around social needs. And I think Iris was mentioning that directly, and the social needs are of a person. So that's an attribute of a person. So staying at the highest level, the community level, COVID-19 Social Susceptibility Index pulls in factors around age distribution in a community, understanding the community's risk for disease burden, common crowding and housing situations, economic stress and access, the infrastructure within the community all affects the ability to seek care, be cared for, and the risk susceptibility to COVID. And we can know that in a proactive way. And we can do that at the state level. Some of our partners in both Maryland and Ohio are doing that right now. The middle area on this slide is looking at that longitudinal risk. So the risk for a risk factor, like we think about clinically for heart disease, a risk factor may be high blood pressure or gender. This is COVID longitudinal risk at the individual level, understanding that person's disease burden, understanding their specific exposure to social determinant risk, their housing situation, their health literacy situation, their social isolation. Many of these comments were already raised and discussed today. So after we have that type of risk view, a common view of risk, then we have an opportunity to look at our population. And I ask the audience to think about the population as anyone you serve. It could be citizens in a state. It could be beneficiaries on an insurance plan. It could be patients within a hospital. It could be an employee situation. So the risk factors help you identify the vulnerable populations. And that's so important as we think about not just COVID susceptibility, but recovery and understanding how the underlying clinical conditions, both social and clinical, play a role in recovery and those primary outcomes. And so those primary outcomes have been talked about in some of the earlier sessions today, but clearly those primary outcomes have to do with health. Notice I didn't say health care, I said health, making sure that vulnerable populations that are impacted by the pandemic, not just by being afflicted with the condition or the sequela of the condition of coronavirus, but are afflicted by the changes in their economic position, the changes in their current healthcare plan, and the changes in their access to care within their areas. And some of that was even discussed earlier by Dr. Logan in the first session, just talking about how the hurricanes have changed access during this pandemic there in Louisiana. The slide I'm showing now, and I wanted to make sure to go through this rather quickly to take questions and be interactive on the panel. It really takes home that opportunity for a common view of risk, to understand geographically where the customers are, to understand where that population is most at risk at scale, and then to understand how that you can drill in specifically on those needs and be able to figure out which parish, which population might have concurrent risk of social isolation and health literacy on top of a reduction in access, or which population may have risks around cultural competence or ethnicity given COVID, or even the underlying risk factors of COVID, like diabetes and heart disease, and really being precise with your programs. We know in Louisiana alone, through our association with Lafayette General, with Beacon, with Holly, with C.N. Robinson and others, that there's many programs that are geared up, and they fall in the supply side, the resources. And these programs are directed towards health literacy. They're directed towards housing. They're directed towards improving social isolation, improving access to care. But where are they best targeted to support that focal population? That's what you get when you have a common view of risk. Let me give just a few examples in one more slide. This is in a state we work with, and in that example, we were able to work as a partner directly with the state. The state developed a task force for vulnerable patients. It's about 3 months ago when this began, well, 4 months ago now. And that task force started with all 6 million members, citizens, if you will, of that state, and then looked at everyone on that state that was in the line of business of Medicare or Medicaid specifically. This state is on one of those waivers, so they have total access to all the utilization claims. By looking at individual and community risk, we discerned down and distilled down to 900,000 folks with elevated individual risk, and then re-stratified to 150,000 individuals with the most risk. And then through that targeting and that support, we were able to turn that information over to the Health Information Exchange, which drove that information directly into their PACE program, their municipal programs around protecting the elderly, and their age programs. So it allowed folks to be supported in place in some of the homeless shelters. But it also put that information right back to the doctors, the providers, the nurse practitioners, the other team members that work and can see their panel and understand whom in their panel has the most risk for COVID. And it's allowed them to be much more focused in their actions. Last slide in here is just a few examples that I wanted to throw out there as best practices that we've seen and our partners have used. I've hit on some of these already. These examples down below have to do with understanding where your homeless populations are, where the folks have the greatest risk for housing instability. That social risk doesn't usually run in isolation. There's concurrent risks, both medical concurrent risks and risks of transportation. And so knowing how that risk profile sets up can help support the program that then is matched from a resource standpoint to those needs. The two other examples here have to do with an elderly program, another group that's at high risk to COVID, and then also uninsured. Understanding that in the situation, as I mentioned, we all have seen the ramifications of the economic downturn and the impact that that has had on jobs and having access to healthcare. And we know that Medicaid as a line of business will go up in its enrollment. My last example before coming to a conclusion is right there in New Orleans. I want you to know that we are partnering with a large national payer on one of their Medicaid plans to specifically provide individual risks around the social determinants of health, housing, food, transportation, health literacy, economic well-being, and develop targeted subpopulations where the resources that are being delivered through community benefit dollars and others can really focus and lift up those team members within the parishes that need it most. So in summary, I'm honored to be able to share some of this work with you guys and gals. I'm humbled that this isn't this time period. What we've learned though is that to address risk at scale around COVID, not just one doctor and one patient, we need to look at the whole picture of the patient, 360 degrees, if you will. I learned that from my early days as an Air Force physician, where I grew up under the patient-centered medical home. So treating that whole patient, their social needs, their clinical needs. So knowing that patient and knowing the community matter. And I think this is what we all want as we try to think about ways we can control to the best of our ability the risk of COVID to vulnerable populations. Jana and Holly, I'll pause there and answer any questions or support the panel.
Thank you, Dr. Bosch. You know, I think the timing worked out well, having Dr. Brown and Dr. Malone speak before Dr. Bosch. You've each built upon the message, but what I've heard was that people first need to trust the messenger when they're getting advice on healthcare, whether it's from a friend or a healthcare provider. So first they have to trust the messenger, and then they have to understand the message. And I'm kind of curious, if I may ask Dr. Brown, are you still with us on the line? Oh, everybody's on it. Dr. Brown, teaching the nursing students, is this part of the curriculum? How do you educate your young healthcare providers to understand the underlying importance of delivering a message that can be trusted? Is that something that's part of the curriculum as we identify all these other social determinants of health? Are you educating on that piece?
Yes. We have incorporated into our curriculum cultural sensitivity. So a large portion of our training, both in the classroom and in the clinical setting, incorporates cultural training. HBCUs have been noted for being a trusted source of information. So we're at an advantage because of that, and even more so now. One of the priorities of the task force that's co-led by Dr. Rebecca Gee has recommended, and we're going to push legislation, is that there will be a required cultural training, racial sensitivity curriculum. It'll be a mandate that medical schools, all schools that prepare healthcare providers, have this threaded throughout their curriculum so that it's not a hit or miss. And so that's how we're able, to reach that population with cultural sensitivity messaging.
Right. And Dr. Malone, if I may ask, you talked about some of the students you've worked with. Are many of the students afraid or embarrassed to admit they don't have access to resources? Are they candid with you, or do you find that the communication is built over time, or do the students show up and admit that they don't have access to water, I don't have transportation? If I'm making sense, like, do you feel that you're getting good communication from the students because you're there on site in their school?
I can hear some of the question, but it's kind of muffled. Can you repeat again, please?
Let me see if this is better. Are you able to hear me better?
Yes.
A little bit. Working in the school-based clinic at Northside High, do you find that the students are afraid or hesitant to admit their lack of resources? Or you being on site, does that break down a lot of barriers to getting appropriate health care treatment?
I think it's both. School-based health centers are known to um, be a good resource for students simply because, number one, they're located on the school campus. And then also it's a place where they gain more trust. They have someone that they can speak to. And so it becomes a place where they can open up and share whatever it is that, whatever problems that they have. So once you gain that student's trust just by seeing them a little bit more often and they see you on the school campus, then they're able to open up. For the most part, I have no problem with them sharing information with me. Some things you don't want to know, but also
TMI.
So I think they feel very comfortable with letting us know exactly what their problems are and issues are.
Mm-hmm.
And, of course, the lack of health care.
Right. Dr. Bosch, where Dr. Malone is, 70501, is a zip code that y'all were speaking of, all of you. It's identified as a higher risk area because there's a higher level of poverty. People may not have dependable transportation, jobs. Once you've identified these areas, though, how do you translate the knowledge to the boots on the ground, getting the resources there to help that population? Is that too big of a question?
To a community work with partners. Are you able to hear me okay?
We can hear you now.
Okay, thank you. So I wanted to emphasize that the data would help match need with supply. So often our partners, health systems and payers, have existing partnerships with community benefit organizations that are delivering benefits around health literacy or transportation support or other benefits around access to care. And so we are able to support the allocation of those resources on that final common mile, if you will, directly to the patient group. I want you to know, though, it's so much depends on the community. So with advanced analytics, you can learn more about the food insecurity in a given area and understand what might be the language spoken in that area, what might be the food sensitivities in that area, understanding the concurrent social risks more than just food, a well-rounded solution that supports the entire group rather than just one patient in one provider's office at one hunger. So the short answer is we have to work through partners that know the communities and help really extend that knowledge that they have already.
This is what Beacon Community Connections is all about. Holly, I'm going to turn this over to you, but this is what you've been working on to get access to care to those most in need. I know you've got some questions.
Yeah, so I mean, really, and Ryan and I have talked, before about this. One of the great things about the 21st century is big data, and socially determined, and there's some other companies out there that are doing something similar that are able to take this data, and I'm not a technologist, so I'm always in awe of people that can do this, and really turn it into actionable information for a variety of people, healthcare providers, that could be hospitals, that could be insurance companies, as well as government agencies. So, Tina that we talked to earlier, and then Dr. Brown being on the health, chairing the Health Equity Task Force, and then comes down to even people that kind of, I see Beacon as really bridging the gap between healthcare and social services. Because what we know about, and Ryan earlier said, I'm talking about health, not healthcare, is that 80% of a person's health comes from where they live, work, and play. It comes from these social determinants of health. Only 20% of your health is really derived from health care. Not that health care is not important, because I'm a big believer in healthcare, but it's just when you're looking at a holistic view of a person, you have to take all those things into consideration. And healthcare providers are stretched, all the time. And Iris was talking about, Dr. Brown was talking about it too, the medical mistrust. The patients come to Iris after they leave the doctor's office. I didn't understand them, and maybe the doctor didn't take time or didn't have the time to take to really sit and work through them so they have understanding. So I know I kind of rambled a little bit. I hope I answered the question. But I guess the question that I have for each of the panelists really is, each of y'all kind of touched on communications and medical mistrust, and I'm wondering how each of y'all would seek to improve patient and provider trust and communications. What do you see as some of the solutions for that?
I can take the first crack at that. I think we as providers need to be better listeners. Often the message is first about relationship and trust. And if we can be better listeners to what's going on in our patients' lives, then I think we'll have more opportunity to help support that patient's choices. I'm humbled as a doctor to know that despite thinking I'm a good doctor and knowing I'm board certified, that 50% of the prescriptions that I prescribe, my patients never take, ever. Like I said, I'm humbled. I think I'm better than that. I want you to know, but I have to say that is what is out there. So I would start with being better listeners.
I would echo that. I train nurse practitioner students, and the first thing that I tell them is to build a trusting relationship with your patient. You can learn what's going on with your patient. 80% you can arrive at a diagnosis just by listening. What my patients often tell me is that the doctors, they're feeling that they're talked at instead of listened to. And so I think as healthcare providers, we have to do a better job of listening. And Dr. Malone shared that, some of the patients, we did a small study where we had two nurse practitioners go in the room, one sat and one stood and talked to the patient. They were in there the same length of time, they delivered the same amount of money. Same amount of message. When we surveyed the patient afterwards to ask who got the better care, hands down, they said it was the provider who sat, looked eye to eye and listened to them. They both delivered the same message, but it was the delivery, the posturing, and that sent the message that I hear you, I'm listening to you.
And I didn't hear the full question, but I can understand through the conversation that we're talking about how we can be better providers. And so what Ryan had said was true, that I've had patients to actually tell me who had gone to the ER and said, I got a prescription for some medication, but I tore it up and I threw it in the parking lot, So because they were coming back to us at another clinic that we have for uninsured and homeless. And we were wondering why are they coming back? And it's kind of like they didn't listen to me. They didn't hear what I had to say. And I'm still having this problem. And that's all they did was just shove me a prescription that I can't afford. And so I just tore it up because I knew I couldn't do anything with it. So we had to listen to what their issues and their problems were and see what's the best way we can help to resolve that particular problem. Some things was very simple. Didn't take a whole lot to be able to resolve, And so again, I was somewhat surprised that some of the patients were not I guess, listened to as well as they should have, and so that they did not receive the care that they should have.
You want to roll into sand? Oh. What's that? Okay. Say it again. Okay. Yeah. Is there anything that we didn't cover that you wanted to, like a passing thought that you?
And at some of the.
Can you all hear me? You can hear Ryan? Is there
Yes.
any parting thought you thought we would touch on that we didn't discuss? Is there anything we left out that you'd like the audience to know before we conclude our session?
I have one thing. I think it's important for us all to think about the distribution and the support of the vaccine as we approach 2021, knowing that it is disproportionate in the community that COVID risk affects. And we need to be extremely thoughtful at scale in our states and in our communities, getting vaccine to where it's needed most.
Thank you.
I would echo that as we move forward with, vaccines, to make sure that we are getting trustworthy messaging out, we're dispelling myths, and that the vaccine as a priority goes to the vulnerable populations first who need it the most.
Right, and as Dr. Brown said, dispelling the myths, because within the last, few weeks, in fact, my COVID testing, and then we also had voter registration, that kind of stuff. And so as we go out into the communities and try to get people to do more testing, I had to, here at the school, that's something that I can provide to the students, but I had to get, of course, parental consent. And one of the things that as they were looking at, I was explaining to them about COVID testing, and we can also, as a school-based health center, provide immunizations and flu vaccine because of the upcoming flu season that's coming up. And the first thing that they said was, I don't mind signing for that, for the immunization, but I don't want that that COVID stuff. But they thought it was they thought it was a vaccine. And so they think that the vaccine is out versus just ongoing testing. I said, we don't have a vaccine at this time. I said, but so what you're signing for is you're giving me permission to do COVID testing. But there's some misunderstanding that I guess they're thinking that there are vaccines, and a lot of them are refusing to have a vaccine for COVID whenever it comes out. And they are also leery about having the flu vaccine as well. Because if mama or grandmother didn't take it, I'm not gonna take it. Or if grandma had a reaction to it, then I might have a reaction to it. So I think it's gonna be a lot of education and also awareness of how it can help that person going forward.
Right. I want to thank you all for sharing your expertise with us, Dr. Iris Malone, Dr. Sandra Brown, and Dr. Ryan Bosch. You're really the boots on the ground in different ways that mirror each other. And I feel like I learned so much today from your thoughts. Thank you so much for joining us. Will you please thank our panelists?
Thank you.
Thank you so much. Best wishes as we move forward. We're ready for Sam? Yeah. I think we'll just stay here instead of taking a break. And our last speaker.
Yeah, we're almost to the end of the morning. It's been a lot of preparation, but the morning has flown by. But I feel like I've learned just so much.
Well, Holly, at the beginning when I started speaking, I was mentioning that this whole conference was really going to be about the social determinants of health. That's something that I wasn't familiar with, I guess, just a year or two ago, and this is really what you focus on. But each of the panel members have delivered a different piece of this puzzle.
Mm-hmm.
But there's still so many people we're talking about that they don't have access to care and they don't even know where to begin.
Mm-hmm. Yes, and so, the original summit that we planned for 2020 was going to be around social determinants of health, but don't worry. We still have all that planning material, and
Next
we're going to
year.
come back in 2021 and really do a deep dive into social determinants of health. And I think, you know, you can't, you know, when bad things happen, a lot of people, you know, we try to find the good in things. And so one of the good things that's come about is that I think that there is a renewed interest in health inequities, health disparities, social determinants of health. And I'm hoping that what we're learning as we move through this pandemic about these health inequities, we can apply that to just general health and well-being as we move forward, because it is something that we need. As a community, we need everyone to be healthy. We need everyone to have a sense of wellness.
Right.
And so I think we're ready for
Sian?
our final speaker of the summit.
Yeah. And this is always a pleasure. Hi, Sian. This is always a pleasure getting to hear from Sian Robinson, who brings his heart, his intellect to the table. And he's going to be talking today about future trends and a call to action. Sian Robinson is Lafayette General Health Executive Director of Innovation, Research, and Real Estate Investment Fund, the Opportunity Zone Fund and Research Department. And he has also been a key advisor